তার মানে তোমাদের responsibility has increased. Until the oath taking ceremony was not there, we were just bit casual and careless. Now, I would say today in superior extremity, the first metacarpal joint. Now, it's a small joint, but a question comes. Even in Viva, you will be asked. So, just a small talk. Now, the articulation between the trapezium and the saddle-shaped base of the first metacarpal bone. Now, this is the first metacarpal bone. You can see, and this is the trapezium. You see this is the facet for the scaphoid, and this is the trapezoid. The other day, I gave a schematic diagram on the board. You try to, again I'll give you the picture of that, because you get a very good idea, and you will be memorizing easily. Now see, this is metacarpal 1, 2, trapezoid and trapezium. Now this is the area, and you see the trapezium over here, the facet for the scaphoid, and this is the trapezoid, this is the scaphoid, and this is for the, and this first metacarpal point. Bone. Now I told you the general lecture on the joint. In the superior extremity, this type is synovial saddle-shaped joint. The capsule surrounds the joint. Synovial membrane, this lines the capsule and forms a separate joint cavity. The lateral and anterior and posterior ligaments. Now, the bones, any bone has to be supported. You can see attachments of ligaments. Now, that to keep that bone in position and place. Now, see the ligaments. The broad lateral ligament, lateral surface of the trapezium to the radial side of the base of the metacarpal bone, base. The broad lateral ligament, lateral surface of the trapezium to the radial side of the metacarpal base. The palmar and dorsal ligaments are oblique. Now, unique facts, the first metacarpal bone more anteriorly situated than the other. If you see your own hand, try to relate your anatomy on your friend and your own body. It becomes very easy if you relate. ধরো শীতকাল, এখন হয়তো একটা চাদর গায়ে দিয়ে বসলে বন্ধু বান্ধবী যে আছে, এবার you see all the points, the bony features and the muscles involved in any part of the body. Now it undergoes medial rotation through 90 degrees so that dorsal surface becomes lateral. Now the dorsal surface becomes lateral, and the movement of the first metacarpal joint is very, you can get all the types of the movement. Unique facts: flexion accompanied by medial rotation. First causes shape of the articular surfaces which impose some conjunct rotation. The obliquity of the dorsal ligament. Movement. Now you see the flexion, extension, abduction, adduction, circumduction, conjunct medial and lateral rotation, and opposition. So you can see the movement of the hand: adduction, abduction, rotation, flexion, extension, and see why you have to be very careful, because it is the hand. It is the most important tool. If your thumb goes, then you can imagine you have to again retrain your brain and retrain your left hand to write. So if an injured person comes to you for any injury, with an injury in the hand, please, with quick your inspection, and also you feel if there is you just feel if there is a fracture or not. I'm saying he comes to your emergency table. Now you just see the movements accordingly. If there is any movement which is restricted, then you quick, with an observation is bleeding, then you put a blood pressure cuff and you raise the blood pressure. Then the arteries are compressed. It acts, your blood pressure instrument for the upper limb acts as a tourniquet. A rubber catheter near so, tourniquet here so. No, you just put in and you just drag and you increase the pressure and hold it. Then it comes bloodless. And you just swab and see if what stitches you have to give, what injury, any muscle or deep injuries, any fractures or not. But I would suggest, for my own practice, that you first repair and give a first aid dressing, and then you send for an emergency radiograph of the hand. Eta tomar, when you are giving treatment, this will be your goal and protocol. Eta por eta korte hobe. যেমন দুর্গা পুজো, এনি পূজা দশকর্মার ফর্দ হয়, প্রথমেই গণেশায় নমঃ করা হলো গাঁজা, তারপর 1 2 3 তিল এই ওই হ্যান ত্যান করে একটা 105টা জিনিস ছোটোখাটো নিয়ে একটা পূজার ফর্দ হয়। Similarly, when you are attending any patient, you just go and give the points and send him, give an analgesin for a radiograph. If the emergency department is equipped, immediately in the your next room, then you just give a small dressing, repair, and don't give a bandage. So the image, though you are having very much these digital radiographs, but anyway, any covering of this thing, that gives a bit, you won't get the fine, this thing, because if there's a fracture, then you have to put a splint, একটা মানে কার্টনাস ওয়্যার বলে, ওখানে তোমাকে এরকম ফ্র্যাকচার হয়ে গেছে পুরোটা, দেন support. Okay. Now, In emergencies, if there is a small over here, then you give a whiteboard needle, IV set, you put it through and through. Now, so ligaments here support. This is the ligament, this is the fractured area. This is the fractured area. The quicker you immobilize, the faster the healing process. Okay. So, our movement, even if there is injury, you have repaired, you have given the first aid, then you tell to yes, flexion, extension, circumduction, how much he can, but he will be having pain. But early movement, then it becomes like this. So, you realizing the anatomy of the hand, you have to give a support in that form and also early movement. Otherwise, it becomes stiff. Imagine the small ligaments, only one vessel supplying the ligament, one minor vessel. Of course, at a gross injury, but try to preserve and save any part of the body. এলো ফুটফাট কেটে দিলে, সেলাই দিয়ে দিলে, বা ভাইকে বলে দিলে যে যারা এক্সপার্ট তারা এক্সপার্ট, কিন্তু 20 বছর 30 বছর সার্ভিস দিচ্ছে ক্যালকাটা মেডিকেল কলেজে যে ইমার্জেন্সি ভাইরা থাকে, হ্যাঁ, জেনারেল ডিউটি অ্যাসিস্ট্যান্ট GDA, they give very good sutures. In Bardwan Medical College in our time, there was a person who used to reduce and give plaster, assisting the surgeons in the emergencies or in the outdoor. So, now early movement, because of the intricacy and the anatomy of the hand. ধরো আমি কেন বলছি, you go to a beauty parlor. Now I want to do my eyebrow. Then what they don't pluck with scissors, they don't cut. একটা সুতোকে নিয়ে বেঁধে একটা দাঁতের টেকনিক আছে, খুব সুন্দর করে সরু করতে চাও, মোটা করতে চাও, এটা করে. And that is possible because of the hand. So, you have to save the hand. Now, movement, flexion, extension parallel to the plane of palm and anterior-posterior axis. Now, you can see the flexor pollicis brevis and opponens pollicis. These are the muscles which come into action. The flexor pollicis, this brevis and opponens pollicis, opponents. Job kora. Okay. Now, extension. The abductor pollicis longus, extensor pollicis longus and brevis. The extension, see, it goes like that. It goes like that. Okay. Now, the muscles involved in moving the abductor pollicis longus, extensor pollicis longus and extensor pollicis brevis. Now, you can see abduction, adduction at the right angle to the palm transverse axis. Abductor pollicis longus and brevis. Abduction. The abductor pollicis longus and brevis. Abductors. Adduction. Adductor pollicis. According to the movement, to memorize, according to the movement, the muscle involved is named. Now, opposition, the pulp of the thumb can touch other fingers. It is Jopin paper. Om Shanti. Okay. Now, combination of abduction, flexion, medial rotation. Abductor pollicis longus and brevis initiates, and flexor pollicis brevis and opponent pollicis maintains. Now, circumduction movement. Okay, all movements, abduction, adduction, flexion, extension, in any order. Say, if an injury is here in the thigh, bone fractures, then there is severe hematoma, but it has some space to accommodate that. If you give a blunt injury or a sharp injury in the liver or kidney, if there is bleeding, then it gives space in there. But in the hand, the space is limited because of the intricacy of the anatomy of the bony structures and the muscles and the nerves and the ligaments and the fascias. Now, with palmar fascia, including fibrous flexor sheath of the digits. Now, thickening of the deep fascia. I think palm of the hand is not, you have dissected the forearm, then now you will come into the palm. Naturally, you will get everything. Everything is visualized. Every ligament, every tendon, every the flexor retinaculum, the palmar aponeurosis, and flexor sheaths of the digits. Now, if there's any inflammation or any infection, then the facial, the mechanism of wound healing and this thing is a complex process. But there is always some, after inflammation, there will be exudate. Now, will that exudate convert to pus or it remains? But in the era of good antibiotics, then you have to be very selective and give at any, in the emergencies, you don't go for a swab test or something like that, because that microbial this thing, sensitivity test for antibiotic comes after 4 days, that means 72 hours. So, amongst the what type of injury he was, if it's a machine injury or some road traffic accident with bruises and cuts, then accordingly you give a high spectrum of antibiotics. Because by the time you graduate, you become a doctor, many molecules, new molecules will come. So I won't be saying ampicillin, I won't be saying cifran, I won't be telling you cefuroxime or something like that. But anti-inflammatory drugs you have to give. It be now thickening of the deep fascia. Now the flexor retinaculum, the palmar aponeurosis, and flexor sheaths of the digits. When you will dissect the palm, you will see each part. Or if your dissected part is shown to you, you please verify. ওই দেখিয়ে দিল অগ্নিমিতাদি এমনি করে দেখলে নিলে ডোন্ট পাঁচজন করে দেখে নাও, then go and sit and review in your dissector and study. If you have a Cunningham dissector, you are having a dissector, Cunningham. Okay. Anyway, but Cunningham dissector is the unique dissector. Flexure retinogram, a strong fibrous band converts anterior concavity of the carpus into a tunnel, carpal tunnel, medially attached to the pisiform bone and hook of the hamate. Okay, laterally attached to the tubercle of the scaphoid and crest of the trapezium. The other day, the diagram I put in, you just block structures if you see it. Then you from medial to lateral. এখানে তুমি just level it and see. Okay. Now structure superficial to the flexure retinaculum. Structure superficial, medial to lateral এরকম করে বলা হবে. And now the palmaris longus tendon, palmar cutaneous branches of the median and ulnar nerve vessels, superficial palmar branch of radial artery. এগুলো সব দেখতে পাবে, ঠিক আছে? দেখে নেবে, একবার দেখে নেবে। মানে তাহলে আরেকটা কি, নাও দি ভেসেল দুটোই তো নার্ভ, রেডিয়াল আর আলনার, তো সেগুলো তুমি একটা ডিপার স্ট্রাকচারে যখন যাবে, দ্যাট একটা কনসেপ্ট দ্যাট উইল সাপ্লাই অ্যান্ড দি সুপারফিশিয়াল পার্ট অফ ইট। ওকে, structures deep to the flexor retinaculum, the median nerve, flexor pollicis longus tendon, flexor digitorum profundus tendon, flexor digitorum superficial tendon, flexor carpi radialis tendon. Palmar aponeurosis. Now this can be a short question, 5 marks, 10 marks, jai ho, with its now parts central, medial and lateral, palmar aponeurosis. Central part palmar aponeurosis proper and medial part covers the hypothenar muscles and lateral part covers the thenar muscle. Now hypothenar, a portion to the, when you dissect, you see the thenar muscles, and this is the covers the lateral part covers the thenar muscles. Now palmar aponeurosis proper, it's triangular in shape. This is the part. Proximally bends with flexor retinaculum, proximally here. Medial and lateral palmar septa extending from the margins. Intermediate fibrous septum extending to the palmar surface of the third metacarpal. Septa divide the palm into fascial line spaces. So each septa গুলোকে একটা মানে that tendon has to glide, টানেলের মতো হয়ে যায়। তুমি নিজেরটা দেখো। ওকে, intrinsic muscles of the hand, thenar group of muscles, abductor pollicis and adductor pollicis, hypothenar group of muscles, and palmaris brevis, lumbricals, palmar and dorsal interossei. Now, the dorsal interossei and the lumbricals, they are very important. So and most of the injuries of the hand, you do local anesthesia. Either if you have an anesthesia, then you block the brachial plexus, or locally if you block in between the interdigits একটু করে xylocaine দিয়ে দিলে হয়ে যাবে পায়ের even if you do any operation for infection of the nail paranoia you can just in between the great toe you laterally medially you inject 2 ml 2 ml or 1 ml 1 ml and wait for 5 minutes it's anesthesia even when you are putting if there is a small fracture or displacement, then you put that needle. I mean, locally you say in this part you will give this thing, this part you give an anesthesia. Then you put the needle inside. It will go through either the bone, if not, at least it will give you a support like this. Okay? Now, the muscles, lumbricals, palmar and dorsal interossei, here thenar and hypothenar muscles. This is the hypothenar and the thenar muscles. These are the lumbricals, these muscles. And you can see the flexure sheath tendons. Now, the lumbricals. See the lumbrical muscles. তোমরা ডিসেকশনে আজকে দেখে নেবে if you get an opportunity or when your teacher demonstrates to you you have your dissector and atlas and correlate the lumbricals, the interossei, the muscles of the hand. Now the palmar interossei. Now, these muscles, see this arrow, the deep transverse metacarpal ligament, palmar interossei muscles, it is a unipinnate muscle. Unipinnate, bipinnate muscles, when you read the general anatomy of the muscles, you can see a beautiful picture by Netter. Netter, I was fascinated by his drawings and still I am fascinated. And Siba Gaigi, Unake, he was a doctor. Americate Unake, artist hishebe, he was given job. And he had done medical illustration in such level আমরা যারাই শিক্ষকতা করি আমরা যারাই মেডিকেল সায়েন্স পড়ি তার নেটারের রেফারেন্সটা আমাদের লাগে in every part of the body it may be pathology it might be gynecology it might be this thing he went on drawing smoking a cheroot you see a picture of the Netter atlas it's now become cheap. Now you see the arrows over here. This is the anterior palmar view. It is like this. Now, now the abduction, adduction. So these are the interossei muscles, you see. Now, mid-palmar spaces. Now, with that introduction, now triangular in shape. It is like this. In front, flexor tendons of little ring and middle finger, third and fourth lumbrical muscles. Behind, third and fourth interossei and metacarpal bones, lateral intermediate fibrous septum, medially hypothenar muscles separated by medial palmar septum. মানে একটা কম্পার্টমেন্টস তৈরি হচ্ছে sheath naturally that gives the spaces now medially hypothenar muscles separated by medial palmar septum, proximally closed by the flexor retiniculum, distally extend that's diverticular to the web of the fingers. Now, amongst you, someone become a plastic surgeon and only a hand surgeon. You will be reading or you look into the internet, they amputate your limb is being 12 hours operation, they are trying to join the muscles, the nerves and everything. And the thing is that they now thinner space, it is এগুলো এক একটা কম্পোনেন্টের শর্ট নোট 4 or 5 marks you will be getting. And the what is thenar space? It's triangular in shape, in front flexor tendons of the index finger, first and second lumbrical muscle. Behind adductor pollicis muscle, transverse head, first and second interossei and metacarpal bones. Laterally thenar muscle separated by lateral palmar septum, medially by intermediate palmar septum, proximally limited by the flexor retiniculum, and distally extend as the diverticular to the web of the fingers. So the flexor retiniculum here, you have the thenar muscles there, the septum laterally, medially. Huh? Now, pulp spaces. Spaces between palmar skin and distal phalanges of all digits. Skin connected to periosteum by fibrous septa. Space subdivided into tight compartments. Infection of pulse space is known as Whitlow. Pus drained by lateral incision. Now this is very important because কি হয় pus is collected. তুমি একটা কি our mind works central at incision দিয়ে দেবে, no, lateral incision. Okay, now and it is very painful, very painful. In 1983, my thumb would be lost. I dressing a wound, burn wound. This thumb, you see, the shape is a bit distorted, and I had a swollen thumb. No drug was sedative drugs, pethidine, Campos. They did not work, and I was only crying and saying, "Amar হাত চলে গেল." আর তখন অ্যান্টিবায়োটিক এত ছিল না, একটা কিছু ছিল বোধহয়, ছিল তো নিশ্চয়ই, পেনিসিলিন the first antibiotic, and the space of Perona. Now this is even হ্যান্ডের উপরে ছোট 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 মানে কোয়েশ্চেন আসতেই পারে, মানে এই তোমার এলবো জয়েন্ট নাও পাস করতে পারো, কিন্তু এগুলো ছোট দুটো একটা কোয়েশ্চেন এসে যেতে পারে। Now space of Perona situated in the forearm adjacent to the wrist, space between the pronator quadratus deep and the flexor tendon superficial. Now you will see when you dissect the pronator quadratus, quadrangular muscle. Now superficially the flexor tendons. আমরা তো সবই এখন flexor region-এর কাছে, posteriorly. Now proximally related to the radial and ulnar bursa. This is the picture. Now space of Perona in front, flexor digitorum profundus and flexor pollicis longus, behind pronator quadratus, on each side outer and inner borders of the forearm. Anatomical snub box. This is again a 10 marks question. Or when you are doing OSPE or the osteology, the examiner, you are going for a gold medal or you want to go for honors. তো একটু এক্সামিনার তো স্ক্রু করবেই, সেটা তো দেবে না, to express his love, to give you more marks. So you know the term screw is used in any other term you can think of. Okay, now the triangular depression on the radial side of the wrist becomes visible when thumb is fully extended. এরকম একটা দেখবে এইখানটায়। You see your own hand, ঠিক আছে? At least in the Viva and without snap box তুমি হারিয়ে গেছো। So you just say, sir, this. Then slowly he asks you what are the boundaries, what are the contents of the, Then you তখন ওই স্কেটসে দেখবে, যখন স্কেটস পরে হেঁটেছো কখনো, তো স্কেট যখন এমনি করে হাঁটে, একটু করে হাঁটে, তারপর করে রোল অন করে, তো ইট ইজ লাইক আনসারিং আ ভাইভা examination. And now anatomical snap box, laterally abductor pollicis longus and extensor pollicis brevis, medially extensor pollicis longus, roof, skin and fascia crossed by cephalic vein and superficial branch of the radial nerve. এখান থেকে cephalic vein and superficial branch of the radial nerve, and floor styloid process of the radius, scaphoid, now bony boundaries. Now the styloid process of the radius over here, and scaphoid and trapezium, base of the first metacarpal bone, content radial artery. Here is a beautiful illustration. You can see this is the extensor retinaculum. এগুলো খুব ভালোভাবে ডিসেকশন করে দেখে নেবে, তার সঙ্গে ইউ সি অ্যান্ড কোরিলেট। তোমার ওয়ান্স সুপিরিয়র এক্সট্রিমিটি হয়ে যাবে, ইউ উইল গো টু ইনফিরিয়র এক্সট্রিমিটি, দেখবে অনেকগুলোই যেটা বলেছিলাম যে উইথ এভলিউশন of erect posture, the things are more or less quadruped থেকে আমাদের এসছে। এবার সেইটাকে কোরিলেট করে তখনই দেখবে যে পায়ের তোকারে রেটিনাকুলা আছে, হাতেও যেটা আছে। নাও ইউ ক্যান সি রেডিয়াল নার্ভ, সুপারফিশিয়াল ব্রাঞ্চ একবারে মোটা, এই দেখো। আর এটা এক্সটেন্সর পলিসিস ব্রেভিস, this is the radial artery, this is the abductor pollicis longus. Now this is the hand, you see shadow. You see there are in Kolkata there are two brothers who arranges shows by shadow, the images. So you can see this is a dog, this is a goat, this is a similar type sub animal is there. See, you can see how the fingers, and তোমরা নিজেরাও একটা ধরো এরকম করে সাপ দেখানো হচ্ছে, তুমি তো অন্ধকার করে দিলে, একটা টর্চ দিলে, লাইট দিলে, দেখবে you can see this type of images, and the intricacy of the now this is a butterfly, this is another animal, this is a cat, this is a rabbit. এগুলো তোমরা নিজেরা দেখো না, প্র্যাকটিস করে, ওকে? কারণ হাত নিয়ে খেলা সব, জাদু, পিসি সরকার, even a surgeon, a physician, Susrut, Charak, and Hippocrates. You see that big picture when you enter in the anatomy department. You see the Hippocrates had is palpating the liver. That picture has a very good meaning that ওই ছবিটা দেখে তুমি মানে অ্যানালাইজ করবে যে কোনো ছবি ধরো তোমার গার্লফ্রেন্ডের ছবি তুমি দেখছো তো সেখানে তার ভুল ত্রুটি কোথায় মেকআপের ভুল ত্রুটি বা লিপস্টিকটা কি রং হয়েছে তুমি তো তাকে ফোনে বলছো এখন ফোনের যুগ বা তোমার ইয়েটা তো এই যে অভিব্যক্তি এক্সপ্রেশন the hand is I told you every part of the body but these two things be very possessive or you just don't go hey that kai bada don't or hey that তারপরে থামস আপের বোতল খুলছো গোল ঘরে এমনি করে দাঁতে লাগে দাঁতটাও তো যা হওয়ার হচ্ছে তার সঙ্গে হাতে একটা ইঞ্জুরি হয়ে যাবে তো উইথ দিস থিং আই টেল ইউ ইউ হ্যাভ টু টেক কেয়ার অফ ইউর হ্যান্ডস তো ম্যানিকিওর তো আ পার্ট অফ লেডিজ দিস থিং বাট আই উড সে ম্যানিকিওর মেন শুড ডু পেডিকিওর মেন শুড ডু দেখবে একটা ভালো টাই ফাই পরে শেরওয়ানি পরে যাই জামা পড়ুক কিন্তু সেটা হয়তো 10,000 টাকা কিন্তু তার জুতোটা হচ্ছে শ্রীলেদার্সের 500 টাকা 6 মাস চলে শ্রীলেদার্স ঠিক আছে কিন্তু আমি ইনভেস্ট করছি একটা জামাতে কোট স্যুটে হ্যাঁ সেখানে কিন্তু টেক কেয়ার অফ এভরি পার্ট অফ ইয়োর বডি এভরি পার্ট এখন থেকে আমরা তখন কি করেছি যে চল চল স্মল পার্ট অফ ইয়োর টাইম ইন আ উইক ইউ প্লিজ মেনটেন ইয়োর ফুট অ্যান্ড দিস থিং দ্যাট কিপস ইউ স্ট্যান্ডিং অ্যান্ড হ্যান্ড ইউ আর ইউজিং ফর ইয়োর প্রফেশনাল এভরি পার্সন থ্যাংক ইউ
This is a class which you require to listen carefully because once you will be graduated, that means once you will pass MBBS, what is your duty towards the society? To serve people. Fine. To serve people, to treat people. Is it? Once you will complete your MBBS degree, you will be authorized, or what I should say, you will be eligible to get a registration certificate from NMC as well as your own state, okay, where you like to practice. Your ultimate motto or aim is to serve people or to treat people, the same thing. Clear? Usually what happens, you see, when you go to treat the patients, what you will do, what a doctor does, firstly, when a patient comes to you or when you go to visit a home of the patients, first things, what you have to do with the patients or with family members? What is the meaning of this word? Is it visible? RAPPORT, building. What is the pronunciation of RAPPORT? Rapo. Usually this R and T usually ujjo thake. Okay. We usually do not pronounce. We call it rapo. So first you have to build a rapport with the patients and their families. What for? To take the case history of the patients, from the patients as well as from their family members. Is it? So once you start to build a rapport, how you can start? Can anybody tell me how you can start a rapport? Simple, with your friends. Okay, right now, how you can start a rapport with your friends? Automatically, in future, you have to build a rapport with your patients and their family members. How you can start? How you can start? Bolo. Good. That is asking the patients his name, from where he has come. Okay. Then one by one you start to collect the case history of the patients. What for this is required? What for this is required? Your objective is not communications. Your objective is to diagnosis. So by asking questions or by collecting the case history of the patients, that means what is your name, what is your problem, how long this problem persists, right now what problem or difficulty you are facing, this, okay. That will help you or that will facilitate you to diagnosis. What diagnosis? Accurate diagnosis. That means that is very important. So by asking questions, you are collecting the informations that facilitate you to accurate diagnosis. Okay. Then on the basis of these questions, they will answer. They means the patients as well as their family members answer the question asked by you. Is it? Then what to do? What is your turn then? You ask questions. Next turn, they will tell. What you will do? আরেকটু জোরে বলো বাবা। এত তাড়াতাড়ি? No, there is a long gap. Once you collect the case history, okay, that means how you will collect case history? You will ask questions. The patients as well as their family members answer these questions. That means they will tell the questions, answer the questions. What you will do? You will what I am doing now? You will listen. The answers, and all these answers you will keep in your mind. That means you are listening. That is very important. That means you are communicating. So the communication has already been started. Okay. So communication is the core things in your everyday life. If there is any problem about asking questions, then automatically the answers the patients will give, that will be wrong. Automatically your diagnosis will be wrong. Is it? Definitely after asking questions, you will examine clinically. After that, on the basis of the answers given by the patients, you will try to examine the patients. Then question comes about diagnosis, provisional diagnosis. Is it? Provisional diagnosis. Then if you are not satisfied or if you have any query in your mind, yes, it's a probable diagnosis, that will be corroborated by pathological examinations. So the core thing is that here, communications. How to communicate? Everything depends upon the communication. Hello, turn your head here. So everything depends upon your communication skills. If you have the good communication skills, or if you had the accurate communication skills, then you will be able to ask questions. Then question comes about accurate diagnosis. If diagnosis is accurate, then prescription of medicines will be accurate. Okay, perhaps you have the knowledge about the medicine. Definitely, once you have passed MBBS, minimum knowledge you should acquire. Okay, then automatically on the basis of that you can prescribe, patients will be cured. If it is reverse, then patients from the next day, patients will not come to you, they will go to the another doctors. So, main thing is communications. So, communication skill is very important. It is not so easy. Okay? Once you practice, you can acquire the communication skill. One day it is not possible. Once you start practicing, all these things, if you keep in your mind, automatically your skills will be developed. Okay? Now, in the first slide, I have written two words. One is expressions, then is equal to impressions. Expressions create impressions. Expression means the way you are conveying, the way you are talking with the client, client or patients, or with your his family members or her family members. That is the indications. Okay? That create impressions. If you can express yourselves correctly, to the point, and if you can draw the pent up feelings of the patients, gather accurate information, gather the history of the patients, you can create good impressions upon the mind of the patients and family members. Never they will go to other doctors. So, communication is very important. Expression is equal to impressions. Now, little bit, the class is meant for communication skills and the barriers and how to overcome the barriers, how to acquire the skills, what are the skills that I will discuss, I will show you one or two skills also. Communication, this is an English word, okay, evolved from, just for introduction I am telling you, Latin language, okay, meaning is that to communicate, communicability or sharing. Now, without communications, even we cannot pass a moment, is it? It is nearly impossible to go through a day without the use of communications, through mobile phone, through talking, okay, through telephone, whatever may be, okay, gossiping, that is communication, because that is the only way through which we can convey our desire, our want, our feelings, our attitudes, okay, what do you want, how we can express with the help of the only communications, maybe verbally, maybe non-verbally, okay, maybe through written communications. So, what is communication? Communication is nothing but sending or exchanging informations. Exchanging information between two or more persons. So, to have communication, at least how many persons will be required? At least 2 persons will be required. The person sending the message is referred to as the senders. Right now, first you have started, okay, to build a rapport with the patients, that means you as a doctor, you are the senders. And with the persons receiving the information is called the receiver, that means patients. So, you are sending the message, you as a doctor, you are sending the message, and the patients is receiving the message, and then once the patients receive the message, he or she will give the feedback, that the answers. The informations conveyed can include what type of informations you can convey, what type of informations you can send, the facts, the attitudes, the feelings, the concepts, the opinions, the beliefs, the instructions, and even the emotions. Everything can be expressed with the help of communications. That is communication, not only spoken word, okay, gesture, postures, whatever may be, Okay, we can convey the feelings, the attitude, the emotions, everything we can express with the help of the communications. So, there are very many definitions of communications. Just you can remember one or two. Second one is most important according to me. Both are important. Communication is the transmission of ideas. We are transmitting ideas. We are transmitting emotions. We are transmitting skills by the use of symbols, by the use of gestures, by the use of graphics, etc. It's an art or process of transmissions. We are transmitting, that is usually called communications. And next one, communication is the transmission of ideas, feelings and attitude, both verbally or non-verbally, which gives rise to a response. You are the, right now, you are the receiver, I am the sender. So, normally which gives rise to response to the minds of the individual or individuals. That is the definition of communications. Now, features of communications or characteristics of communication. Only I told you that 2 or more persons will be required, number 1. So, 2 or more persons will be required. Then next one, what to communicate? Ideas. Ideas, feelings, emotions, words. Okay. So, exchange of ideas or message. Message means what? Message. Perhaps everybody know about the message. সব সময় তো মেসেজ করছি আমরা। কিসে মেসেজ করি? With the help of mobile phone. Message means what? Idea we can convey. Message means a word. Message means emotions. Message means feelings, everything. Okay. So, that is exchange of idea or message. Second and third one is mutual understanding. That means what I understand, you should understand the same thing the same way. Otherwise, there will be mistrust. That is called lack of communication. That is called miscommunications. Okay. So, mutual understanding must be there. And next one, communication may be direct, may be indirect. This is direct communications, face to face. And if we communicate through another media, say for example, we are communicating with the help of these televisions. We feed a message to the televisions, and with the help of the televisions, the message will be telecasted. So, that is indirect communications. It's a continuous process. There is no end of communication, going on, going on, going on. That is a continuous process. And next, in communications, we use sometimes words, we use sometimes symbols, elements. Now, to be an effective communications, not always, in case of direct communications or face-to-face communications, all these things may not be required, but to complete the cycle of communications, these 7 or 8 elements will be required. Okay. Then when you will communicate, there must be a source. You are telling the patients that you should not eat spoiled food. You should eat balanced diet. Is it? Now, from where you have know? From where did you know this balanced diet? From the book. Okay. So, that is the source. Source means maybe a person, maybe a book, maybe a journal, maybe a newspaper, maybe a periodicals, maybe TV, maybe radio. So, this is the source. Source means where the communication originates. Next, sender. Who is the sender? You. You as a doctor are the senders. Sometimes source or sender may be the same. If I say something from my own, as a doctor, if you say something from your own experience, you can say something to the patients, you can educate the patients, same fashions. So, in that case, you are the source, you are the sender. Is it clear? Sometimes source and senders may be different, sometimes source and sender may be the same. Then encode. Encode means coding you know very well. That is coding means encoding, nothing but when we transfer long sentences into a single word or a symbol, that is called encoding. Next, message, no need of repetitions. I told you message means an idea, maybe a word, maybe a sentence, maybe our feelings that is being transmitted or to be transmitted to the patients, that is the message. Then channel. Channel means media, nothing but channel means media. Say for example, we go quickly, we want to go quickly, okay? So with the help of bicycles, with the help of motorcycles, with the help of four-wheeler, we go. With the help of sight, with the help of train, that is the media through which we can go quickly. Likewise, when you send a message to my friend, to your friend who used to live at USA or Delhi or Kolkata, then you can need কি হলো তাহলে এখানে কেন ও আচ্ছা সরি যাও So channel means a media through which we can send our message. Next is decode. Decode means it's a mental process. Again, it's a mental process through which we can transfer small word into a large one, keeping the meaning intact, the same. That is called decoding. Next is receiver. No need to say. Receiver means the patients who is receiving the message. Hello, last second, কি করছো তোমরা? যদি ইচ্ছা না হয়, go out of the class, I don't mind. Attendance হয়ে গেছে, চলে যাও। থার্ড ইয়ারে ফেল করবে, তখন ফেল করবে। এখন তো নেই, বুঝতে পারবে না। Then last one is feedback. Feedback means what? Response. Okay. This is a simple model, SMCR model: source, message, channel, receiver. Source, message, channel, receiver. So this is the repetition of the same thing that I right now explained about the elements of communication. Same thing. Source, communications originates from the source, it comes to the sender. Sender is sending the message by encoding through a channel. Receiver is decoding the message and receiving the message here in his brain. Then he is giving feedback. From each element, distortions may come. Distortion means fault. Fault may come. If the source is wrong, how it can be wrong? Say for example, there is a printed mistakes. You do not know about the mistakes. So you are committing the same things, you are telling the same things to the receiver. So automatically the distortion may come out because you know you are right. But from where you have committed this one, that is wrong. And বইয়ে ঠিক আছে, okay, but when you are telling ভুলে গেছো, 2 কে 3 বলেছো, so automatically fault begins with the senders, and then again you are sending the message through a channel. Channel is faulty, okay, channel is faulty. Say for example, when you are feeding this message to a channel means a radio or newspapers, it গন্ডগোল হয়েছে. When you are writing, sending the message through your mobile phone, while typing, some error may be there, okay. Then decoding, রিসিভারের এখানটা কম, তুমি যেটা পাঠিয়েছো, what you are sending, সে অন্য মিনিং করছে, okay. So distortion may come out from each and every element, but feedback is very important. Now types of communication, there are 3 types of communication. কি? One is verbal, one is non-verbal, another is written. ডিসকাস করার কোনো দরকার নেই, চলো। Principles. Now these are not very important for you, automatically you can grasp it, but I am telling there are 4 principles of effective communication. Number 1, the perception of the sender and the perception of the receiver should be as close as possible. What I am telling, okay, you are receiving the same things. What I will tell, if you can understand, that means perception of the receiver and perception of the sender will be close, then communications will be effective. And second one is, for effective communications, there should be involvement of more than one sensory organ. How many sensory organs do you have? 5. Okay. So, at least while you will communicate, try to involve more than one sensory organs. I am involving at least 2. One is mouth, that means ear, you are listening and you are visualizing with the help of your eyes. So, communication, I suppose it will be better. And third one is, the more the communication takes place face to face, more it will be effective. This face to face communication will be effective because you see, I can read your face, you can read my face, you can have the opportunity to view my facial expressions. Okay, that is the third principle. And last principle is feedback. If there is a opportunity of feedback, direct feedback, immediate feedback, timely feedback, then communication will be effective. If you cannot understand, you can ask me, I can explain you, or if I cannot understand what you are trying to tell me, I can ask you once again, then it will be clear. So, these are the 4 principles of effective communications. Now the question comes about the skills of communications. Skills. Communication skill for the doctors. A doctor's communication and interpersonal skills encompasses what? The ability. What for? The ability to gather informations. That I told you previously, to gather information. What for? In order to facilitate accurate diagnosis. That is very important. Communication skills. That means ability to facilitate accurate diagnosis, then counsel appropriately, then give the therapeutic instructions and establish caring relationships with the patients and their family members. That is the communication skills. Okay. Now, skills of communication. First one is so there are very many skills. The first one that is most important, many times we ignore, that is called active listening. What happens, you see, practically, when a patient comes to you, you ask 1 or 2 questions, okay, I can understand. No. On the basis of that, you just try to prescribe the medicines. That is not the way of treating the patients for the disease. I do not know whether you have experience or not to attend the specialty clinic. At least in specialty clinic, the doctors or the physicians give at least 10 to 15 minutes per patient, minimum, maybe more than 15 minutes. What they do? They gather all informations, background information, including these feelings, including the emotional problems of the patients. Then he prescribed. That's why time is required. They have the enough skills. Which one? First one is active listening. Active listening means not listens merely. Okay. Listening is one of the essential elements of effective communications with patients and their families. What is that? It is the ability to accurately receive and interpret the message or informations in the communication process. Not only to hear, but to listen, okay, and interpret what the patient is trying to tell you. You have to interpret, তার মানে কি বলতে চাইছে মানেটা তোমাকে এখানে রাখতে হবে। সে ভুল বলতে পারে, ঠিক আছে? ইফ যদি সে ভুল বলে, again you have to question. That is called this one. That is called paraphrasing. Okay, that is another skills I am coming. Okay, active listening is a skills that can be acquired and developed with practice. That is not so easy. মনে হয় যে আরে শোনাটার কি আছে, লিসেন, ও বলছে আমি শুনছি। নো, when you are asking questions, they will tell. Again you have to ask more and more questions to get the accurate history. Then only your diagnosis will be accurate. That is very important. Active listening means actively listening without any distractions. আমি অ্যাজ এ ডক্টর আমি জিজ্ঞেস করলাম, তুমি পেশেন্ট বলছো, আমি ওইদিকে আমার ফোন কল এসছে, আমি ফোন, হ্যাঁ আমি শুনছি, বলুন বলুন। So you are not listening, you are just hearing passively. So that is not active listening. Impression তো গেলই, পরের দিন আসবে না। যদি তুমি বড় হয়ে যাও, অনেক নামডাক হয়ে যাবে, তখন আসবে, বিকজ তুমি এগুলো প্র্যাকটিস তখন করবে না। তখন তোমার এমন ক্ষমতা হয়েছে যে অটোমেটিক্যালি you can be able to diagnose accurately. Okay, active listening means actively listening. It means fully concentrating on what is being said, full concentration, rather than just passively hearing the message of the speaker. Active listening involves listening with all senses. Okay. Now, there are some skills how to become a good listener. শুধুমাত্র ডাক্তারিতেই নয়, সব ক্ষেত্রে কিন্তু এটি প্রযোজ্য, বাট ডাক্তারিতে বেশি প্রযোজ্য, বিকজ 1-to-1 সিচুয়েশনে তোমার উদ্দেশ্য হচ্ছে অ্যাকুরেট ডায়াগনোসিস। দ্যাট ডায়াগনোসিস ডিপেন্ডস আপন দ্য কোয়েশ্চেন্স ইউ আস্কড, আনসার ইউ গেট ফ্রম দি পেশেন্টস। তার জন্যই ভেরি ইম্পর্টেন্ট। আচ্ছা, how to be an active listener? Number 1 conditions, eye contact. Many a times it happens the doctors write, okay আমি শুনছি, ও লিখে যাচ্ছে। Eye contact is very important. চোখের দিকে তাকিয়ে থাকা। If there is eye contact, what is the positive one? Patients or client 4 বার ভাববে যখন সে মিথ্যা কথা বলবে, ভুল বলবে। চোখের দিয়ে তাকিয়ে usually no persons can tell a lie. So eye contact is very important. Eye contact থাকলে কি হবে? What will happen? Patients will think, ও বাবা, ডাক্তারবাবু মনোযোগ, ডাক্তার দিদিমণি, হোয়াট এভার মে বি ডক্টরস, ওকে, মনোযোগ দিয়ে আমার কথা শুনছে। To be an active listener, make proper eye contact with the speaker and focus on his or her expressions and the words. In case of any confusions, you can ask numerous questions. যত খুশি তুমি কোশ্চেন করতেই পারো। আই কন্ট্যাক্ট। নেক্সট ওয়ান ইজ পশ্চার্স। ও আমাকে তো চেয়ারও নেই, বুঝবো কী করে? পশ্চার্স, ইউর পশ্চার্স। আমি বসে আছি এরম দিয়ে হেলিয়ে, ইজি চেয়ারে এরম হেলিয়ে বসে আছি। দ্যাট পশ্চার ইজ নট গুড। ইউর পশ্চার্স, দ্যাট ইজ ইম্পর্টেন্ট। তোমার পশ্চার যদি ঠিক থাকে, দেন পেশেন্টস উইল think that doctors listening, আমার কথা শুনবে, আমি সুন্দর করে বলবো, গুছিয়ে বলবো। তা গুছিয়ে যদি বলতে না পারে, তাহলে তো ডায়াগনোসিসটা গন্ডগোল হবে। পশ্চার্স। নাও be attentive and have a proper body posture. কিরকম? Slightly lean forward to practice active listening. Slightly slant of the head and resting of the রেস্টিং দি হেড অন ওয়ান হ্যান্ড। এই যে আমি বসে আছি এখানে, আমি বসে আছি, দিস ইজ স্টেট। লিন ফরওয়ার্ড, যখন তোমরা বসবে, এই যে ও বসে আছে লিন ফরওয়ার্ড হয়েছে, ও কিন্তু এরকম বসে নেই, এই যে বসে আছে লিন ফরওয়ার্ড, এই বসে আছে, আবার এরম করে আছে, ও আবার দুটো হাত এরম করে আছে। হোয়াট ইজ দ্যাট? দিস ওয়ান, slightly lean forward to practice active listening, slight slant of the head, resting the head on one hand or two hand. আমি শুনছি, আমি পেশেন্টের দিকে তাকিয়ে এরকম শুনছি, হ্যাঁ বলুন। That means patients will feel the doctor is listening, and yes, you are listening properly, showing the patients also automatic, এটা হয়ে যায়। lean forward, আমি এরম করে শুনছি না, আমি এরম করে বসে নেই, straight lean forward, আমি শুনছি, মনোযোগ সহকারে শুনছি, that is called active listening. That's why I am demonstrating you, this is the active listening, this is active listening, definitely all are active listening. You are listening actively what I am telling to you right now. So that is active listening. Some do's for active listening and some don'ts for active listening. The first skill is active listening. কি কি আছে কর্তব্য? Keep quiet while listening. Focus on what the patient or client says rather than on his look. তার চোখের দিকে তাকাবে, কপালের দিকে নয়, কিন্তু কি বলছে তার উপরে ফোকাস থাকবে। Show interest in the patient. একজন পেশেন্ট বাজে পেশেন্ট, বাজে পেশেন্ট মানে কি? আমরা বলি বাজে পেশেন্ট, বাট আই শুড নট সে দি বাজে পেশেন্ট। এভরিবডি হ্যাজ দ্য নলেজ অ্যাবাউট HIV/AIDS, আছে? এভরিবডি নোজ হোয়াট ইজ HIV, হোয়াট ইজ AIDS, জানো তো না জানো না? হাউ ডাজ ইট স্প্রেড, এটা জানো? এভরিবডি নোজ। টু মেক ইউ আন্ডারস্ট্যান্ড অ্যাবাউট দিস, show interest in the patients, I am trying to explain these things to you. It is a patient, show interest in the patients. A patient has come to you, you have enough knowledge, experience about different types of diseases. তোমার শুনে মনে হলো অ্যাক্টিভ লিসেনিং সব শুনেছো, যে তোমার মনে হচ্ছে ও এই পেশেন্টস মে সাফার বাই HIV. So once you know the modes of spread of HIV, even the patient may know, may not know. When you asking questions, you are telling that he or she, whatever may be, visited a red light area. জানো তো red light area? red light area, তখন তোমার মনে কি হবে? কিচ্ছু হবে না। You must be impartial. You must be non-judgmental. প্রথমেই সাধারণ মানুষের শুনে কি হয়, বাজে জায়গায় দেখাচ্ছে, বাজে লোক, মুরগে যা। বাট অ্যাজ এ ডক্টর ইউ শুড নট, ইউ শুড শো ইন্টারেস্ট ইন দি পেশেন্টস। একটা কথা মনে রাখতে হবে, আমরা বলে থাকি, দ্যাট ইজ ভেরি ইম্পর্টেন্ট, কিল দি সিন নট দি সিনার। মানেটা কি? কিল দি সিন নট দি সিনার। বাংলাতে আমরা কি বলি? পাপকে ঘৃণা করো, পাপীকে নয়। সো কিল দি সিন নট দি সিনার, দ্যাট মিনস সে বাজে জায়গাতে গেছে, নোয়িংলি তুমি তাকে ঘৃণা করবে না। ইউ উইল শো ইন্টারেস্ট টু দি পেশেন্ট, বিকজ ইউর ডিউটি ইজ টু কিওর দি পেশেন্ট, টু ট্রিট দি পেশেন্টস, টু গিভ মেন্টাল রিলিফ, to give emotional relief. So you have to show interest in the patients. Next step, let the patient finish his or her turn. Let the patient finish whatever he or she wants to say without interrupting him or her. তুমি ফিল করছো, you are correct, মিথ্যা কথা বলছে, পেশেন্ট ইজ টেলিং লাই। সে তোমার কথাবার্তা শুনে মনে হচ্ছে ব্রথে লেগেছিল, রেল লাইটে গেছিল, ও বলছে আমি যাইনি। তো যাইনি তো হলো কি করে? হতে পারে আরেকটা রুট কি আছে, নিডল এন্ড সিরিঞ্জ, ওকে দ্যাট তোমার শুনে মনে হচ্ছে ও বলছে, বাট তুমি মনে হচ্ছে আগে তুমি জিজ্ঞেস করে নিয়েছো কোথাও রক্ত নিয়েছিলে, রিসেন্ট কিছু কোথাও ইঞ্জেকশন নিয়েছিলে, না না আমি রক্ত নিই। তারপরে ওইগুলো বলছে আমি যাইনি কোথাও, ছড়াবে কী করে, ঢুকবে কী করে? ঢুকতে তো হবে, কোনো রুট তো আছে, ঠিক আছে। স্টিল ইউ শুড নট বি partial, you should not be judgmental. Demonstrate attention. When the patient will say something, nod your head, supporting him. যখন অতিরিক্ত বলছে, telling more and more all irrelevant, then don't nod your head, keep silence. Patients will think, ডাক্তার এতক্ষণ তো এরকম করছিল, চুপ করে আছে, তা আমি যেটা বলছি ঠিক বলছি না, বুঝতে পেরে গেছে। ওকে, সো নোড ইউর হেড, দ্যাট ইজ স্কিল এগেইন। অ্যাট দি সেম টাইম সাপোর্ট হিম। কীভাবে সাপোর্ট করবো দেখো, এনকারেজ দি পেশেন্ট সেইং ইয়েস, ভেরি গুড, ক্যারি অন, টেল আই এম লিসনিং, বলে যান আমি শুনছি। ওকে, অটোমেটিকলি সে কিন্তু মনের কথাগুলো সমস্ত ডিটেলসে বলতে লাগলো। তোমার সুবিধা হবে কি জন্য? ডায়াগনোসিসের সুবিধা হবে। লুক ইনটু দি আইজ অফ দি পেশেন্ট। মিনিমাইজ এক্সটার্নাল অ্যাফেয়ার্স। মোবাইল আমি এনেছি কিন্তু, আই হ্যাভ কেপ্ট মাই মোবাইল ইন দি সাইলেন্স মোড. So don't watch TV, don't watch your watch, okay? So minimize external affairs, TV, telephone and internal. মনের যে আসছে আমার বাড়িতে একটা অসুবিধা আছে, মুছে ফেলে দাও. When you will treat the patients, when you will collect the history of the patients to facilitate diagnosis, accurate diagnosis, try to forget everything, concentrate your mind on the patients. And at the same times, খুবই একটা বাজে ইনজেকশন কন্ডিশন খুব খারাপ, প্রোগনোসিস ইজ ভেরি ব্যাড, ইউ নো, ওকে, সেও জানে। স্টিল হি অর শি হ্যাজ কাম, সো ইউ হ্যাভ টু অ্যাকনোলেজ দ্য পেশেন্টস ফিলিং। আমি বুঝতে পারছি, আই ক্যান আন্ডারস্ট্যান্ড আমরা কতটা অ্যাংজাইটি রয়েছে, খুব খারাপ লাগছে, বাট ওকে, উই হ্যাভ টু ডু আওয়ার ডিউটি বোথ সাইডস। আপনি আপনার কর্তব্য করবেন, আমি আমার কর্তব্য করব, আমি যা বলবো আপনি শুনবেন, আর আমার যা করার আমি করবো, কোঅপারেট তো করতেই হবে। রিপিট or rephrase to check if you have correctly understood the patient, that is called paraphrasing. আমি আসছি প্যারাফ্রেজিং। প্যারাফ্রেজিং কী জন্য করবো? for two reasons, not only one reason. Number one, to make the patients understand that yes, I have listened your all words. That means what the patient told, I am repeating the same things in another versions. Sentence may be different, but meaning will be intact. Number one. Number two, if the patient told anything wrong, ধরা পড়ে যাবে, ও তো মনে নেই কি কি কথা বলেছে। যদি অ্যাকুরেট হয় ফাইন, যদি মিথ্যা কথা হয়, ভুল হয়, সে তো ভুলে গেছে কি বলেছে। তুমি আবার যখন রিপিট করছো, দ্যাট ইজ ফর ক্লারিফিকেশনস। ও যদি ঠিক কথা বলে থাকে তাহলে ঠিক আছে, আর যদি ঠিক না তো ডাক্তারবাবু আমি এটা তো বলিনি, দ্যাট মিনস ফর ক্লারিফিকেশনস। ওকে, সো প্যারাফ্রেজিং ইজ ইম্পর্টেন্ট ফর দিস টু রিজনস। সাম ডোন্টস, কি করবে না ডিউরিং লিসনিং, অ্যাক্টিভ লিসনিং কি করা উচিত নয়। ডু নট ইন্টারাপ্ট দি পেশেন্টস, দ্যাট আই টোল্ড ইউ। লেট দি পেশেন্ট ফিনিশ, দেন অনলি ইউ ক্যান স্টার্ট। অনেক সময় আমরা বলি না, তুমি বলতে লাগছো, আমি বুঝতে পেরে গেছি। ডাক্তারবাবুরা অনেক সময় বলে দুটো কথা শোনো, আমি বুঝতে পেরেছি, আর বলতে হবে না। নো, দ্যাট ইজ নট দি কারেক্ট ওয়ে টু কমিউনিকেট উইথ দি পেশেন্টস। ডু নট ইন্টারাপ্ট দি পেশেন্টস, ডু নট distracted by audio visual knowledge, never. Do not be close minded. What is that? Close minded, ulto open minded. Close minded means, I know that AIDS is not curable. AIDS curable till today? AIDS? চুপ পুরা চুপ আমি জানি না, ও একজনই বলছে AIDS is curable or not till today? Not curable, তুমি জানো। Still encourage the patients, okay? That is called open minded, ঠিক আছে। ভালোভাবে কতদিন বাঁচা যায়? How long we can linger the life? By swallowing medicine, ঠিক মতো মেডিসিন যদি নিতে না হয় তাহলে লাইফ লিঙ্গার হবে, কোনো অসুবিধা নেই। ওকে, সো দ্যাট ইজ কল্ড ক্লোজ মাইন্ডেড। ডোন্ট বি ক্লোজ মাইন্ডেড, ডু নট শো ইউর ল্যাক অফ ইন্টারেস্ট ইন ওয়ার্ডস স্পোকেন বাই দি পেশেন্টস। যে শব্দ ব্যবহার করবে তোমার ভালো লাগছে না, স্টিল কখনো বুঝতে দেবে না আমার এটা ভালো লাগছে না, তুমি আবার রিপিট করবে, তুমি বুঝতে পারছো না রিপিট করতে বলবে। তোমার যে ল্যাঙ্গুয়েজ ও বলেছে, ওয়ার্ডস, ল্যাঙ্গুয়েজ মিনস ওয়ার্ডস, সবাই তো বাংলাতে কথা বলবে এখানে, তো ওয়ার্ড, দ্য ওয়ার্ডস দ্যাট ইজ কল্ড ভার্বেটিম। যে ভার্বেটিমগুলো আছে, যেমন বীরভূমের কিছু ভার্বেটিম আছে, বর্ধমানের কিছু ভার্বেটিম আছে, সিম্পল ওয়ার্ডস, সেই ওয়ার্ডসগুলো বোঝা যায় না, কিন্তু আবার রিপিট করতে করতে ঠিক হয়ে যাবে, ওটা কখনো ডিসকাস করবে না। কি রে মাঝে মাঝে গন্ডগোল করছে। হ্যাঁ, নেক্সট non-verbal communication। কাজ করছে না মাঝে মাঝে রে। Now start non-verbal communications. Body language. Many times always we say body language তো ঠিক নেই। What is that? Body language ঠিক নেই মানে যেটা আমি বলছি, what I am telling I am not doing, what I am telling that is not showing। যেটা আমি বলছি সেটা আমি করছি না। আমি ডাক্তার শুনছেন তো? হ্যাঁ শুনছি, আমি শুনছি না কিন্তু আমার মন অন্যদিকে। ওকে, সো দ্যাট ইজ নন কনগ্রুয়েন্ট। সো ইউ মাস্ট বি কনগ্রুয়েন্ট, হোয়াট ইউ আর টেলিং ইউ মাস্ট ডু ইট। ওকে, সো বডি ল্যাঙ্গুয়েজ দ্যাট মিনস কনগ্রুয়েন্ট, যেটা আমি বলবো সেটাই করবো। বডি ল্যাঙ্গুয়েজ বলে দেবে যে whether I am empathetic or not to the patients. Body language must be congruent. Eye contact, definitely always eye contact with the patients, but yes, sometimes you have to turn your eyes like that. তার মানে তুমি বুঝতে পারছো যে মিথ্যা কথা বলছে, একটু সরিয়ে নাও, তখন ও কিন্তু সত্যি কথা আবার বলবে। Facial expressions, that is most important. How you are telling, what you are telling is important, but how you are telling, that is very, very, very important. That is called facial expressions. Your tone, that is important. জোরে কথা বলা, আস্তে কথা বলা, কোনো লোক আছে জোরে কথা বলে, that is normal tone, but tone, তার মধ্যেও তারতম্য আছে। ওকে, টোন, ভয়েস, হ্যান্ড গেস্টার্স, that is important. Okay, it allows the persons, family members you are speaking with to pay attention to you and actually listen to what you are saying. হ্যান্ড গেস্টারের মধ্যেও এটা দেখা যায়। Next skill is what I told you, active listening, paraphrasing, and next one is I did not tell you, mirroring. Mirroring means another meaning is reflecting. Reflecting, আয়নার সামনে আমরা কি করি? দাঁড়ালাম, কি দেখি? আমার নিজের ফেস আমি দেখছি। So that is called mirroring. When a patient will come to you, communication skill, that is most important skills. আমি তার ফেসটা কিন্তু দেখতে পাচ্ছি, সে থাকছে না, ফেসটা আমার মুখের সামনে চলে আসছে। কিভাবে সে এক্সপ্রেস করেছে, দ্য ওয়ে হি অর সি হ্যাজ এক্সপ্রেস হিজ ফিলিংস, হিজ প্রবলেমস, দ্যাট ইজ কল্ড মিররিং অর রিফ্লেক্সিং। দেন প্যারাফ্রেজিং, আই টোল্ড ইউ, কোয়েশ্চেনিং, অ্যাক্টিভ লিসনিং, দেন কোয়েশ্চেনিং। Question, you have to make questions. What type of questions? That you require only. Out of curiosity, you should not ask any questions. The questions that will be relevant, that will be required to facilitate your diagnosis, that type of questions you will ask. That type of questions you will ask to the patients. Ask relevant questions. Questions are two types. One is open-ended and there is close-ended. Can anybody tell me what is open-ended questions and what is close-ended questions? Clear আছে? Open-ended questions, close-ended pictorial question বাদ দাও আরো আছে, just minimum there are two types of questions. One is open-ended, another is close-ended. What is your name? Yes? Swapnanir Biswas. What type of question I asked? Is it close-ended or open-ended? No, this is close-ended question. তোমার কি স্কোপ আছে আর কিছু? আমি তোমাকে যখন জিজ্ঞেস করলাম তোমার নাম কি, তুমি বললে স্বপ্ননীর বিশ্বাস, আর কোনো স্কোপ আছে বলার তোমার? নো, দ্যাট ইজ কল ক্লোজ-এন্ডেড। ওপেন-এন্ডেড কোশ্চেন কেমন ধরো, হোয়াট ইজ ইউর ওপিনিয়ন অ্যাবাউট দিস শান্তিনিকেতন মেডিকেল কলেজ? কতটা বলতে পারবে তুমি? কেউ 2 লাইন বলবে, কেউ 4 লাইন, কেউ 10 লাইন। ইউ আর ফ্রি টু গিভ আনসার্স, দ্যাট ইজ ওপেন-এন্ডেড। সো অ্যাজ এ ডক্টর তুমি কখনো ক্লোজ-এন্ডেড, কখনো ওপেন-এন্ডেড, অ্যাজ উইল বি রিকোয়ার্ড। কিসের জন্য? টু অনলি টু ফেসিলিটেট ডায়াগনোসিস। সো কখনো ওপেন-এন্ডেড, কখনো ক্লোজ-এন্ডেড কোশ্চেন। কোশ্চেনিং অলসো এ স্কিল। No questions out of curiosity which are not required to fulfill the purpose of diagnosis. Next is question করলে, ও বলতে লাগলো, তুমি শুনলে, দ্যাট ইজ অ্যাক্টিভ লিসেনিং। তুমি স্যাটিসফাইড নাও, আর দুটো কোশ্চেন করলে হয়ে গেল। তারপর এবার তোমার পালা। নাও ইট ইজ ইউর টার্ন। Okay, informing or telling. To be an effective doctor, you should inform your patients about what your conversations would be about. When as a doctor, when a doctor will tell to the patients, আগে আমি বলে নেব as a doctor will tell আমি কি বলবো, the salient points, then only পেশেন্ট কী করবে, তার মাথায় ঠিক করে রাখবে, হ্যাঁ আমাকে ডাক্তার এই বলতে পারে, মাথায় রাখলো, দিয়ে শুনলো। ইট উইল হেল্প ইউর পেশেন্ট টু হ্যাভ এ জেনারেল আইডিয়া অ্যাবাউট দি কনভারসেশন, দ্যাট ইজ কল্ড ইনফর্মিং অর টেলিং। ফার্দার মোর ইট উইল অলসো অ্যালাউ দেম টু গ্রাস্প দ্য নলেজ ইজিলি। আদার দ্যান দ্যাট ইউ শুড অলসো ইনফর্ম ইউর পেশেন্টস, ফ্যামিলি মেম্বার্স অ্যাবাউট দি কি ফিচার্স অর পয়েন্টস দ্যাট দে শুড ক্যারি while going home, they should carry. That means আমরা কি বলি, মেসেজ হোম, টু ক্যারি হোম, কি মাথায় নেবে দিয়ে যাবে। সে ফর এক্সাম্পল কিছু তুমি অ্যাডভাইস দিয়েছো, ইনস্ট্রাকশনস ফর থেরাপিউটিক কজেস। তোমাকে ভালো থাকতে গেলে ওষুধ তো খেতেই হবে, তার সঙ্গে কিছু জিনিস ফলো করতে হবে, অ্যাবাউট ইউর বিহেভিয়ার, অ্যাবাউট ডায়েটিং, অ্যাবাউট আদার হ্যাবিটস, ক্যারি মেসেজ। সেগুলো টু দি পয়েন্ট তোমাকে বলে দিতে, আপনি এই করবেন। দ্যাট ইজ কল কি মেসেজ টু ক্যারি অর টু রিমেম্বার। নেক্সট স্কিল হচ্ছে বি কংক্রিট অ্যাবাউট ইউর আইডিয়া, অ্যাবাউট ইউর ক্লারিফিকেশনস। হোয়াট এ ডক্টর মাস্ট টেল, that must be authentic. What is the meaning of authentic? Credible. আচ্ছা, credible কিছু না, authentic, evidence based. যদি কোশ্চেন করে তুমি প্রমাণ দিতে পারবে, উইথ ফ্যাক্টস অ্যান্ড ফিগার্স। যাই বলবে সেটা হবে কি, authentic, means evidence based. And the skill that you should learn to be an effective doctor is to be precise and unambiguous with your message. Your message will be precise, definitely bullet points এ বলবে, এত বড় বললে তুমি একাই করতে পারবে না, মনে রাখতে পারবে না। and that must be unambiguous, দুটো অর্থ যাতে না হয়, ঠিক আছে? ওষুধ খাবে 12 ঘন্টা অন্তর, 8 ঘন্টা অন্তর, এক্সাম্পল দাও, 8 ঘন্টা, 6টা 2টো 10টা, 3বার যদি খায় 6টা 2টো 10টা, বিকজ perhaps you know and you will be knowing, if you do not know, that the efficacy of any medicines will increase if time gap is maintained, নির্দিষ্ট টাইম। সেই জন্য ওটা বলতে হবে, if a person that tell the whole background story is unauthentic and without any proof to explain your things, then you are not an effective doctor. Okay, give explicit details about the information including facts and figures. Relax. Whenever you tell, whatever you tell to your patients, এরকম করে থাকবে না, সিটিয়ে থাকবে না, ওপেন, রিল্যাক্স, বিকজ ইফ ইউ আর ইন স্ট্রেস এভরিথিং উইল বি রুইন্ড। তোমার যদি স্ট্রেস থাকে, তুমি যদি কনফিডেন্ট না হও, ইফ ইউ আর নট কনফিডেন্ট এনাফ হোয়াট ইউ আর টেলিং টু দি পেশেন্টস অ্যাবাউট দি প্রোগনোসিস, ডায়াগনোসিস, হোয়াট আর মে বি মেডিসিনস, কিওর, এভরিথিং, ইফ ইউ আর নট কনফিডেন্ট এনাফ, patients will not come to you. So that is very important. So you must be minimize your stress, because stress causes you to choose the wrong set of words. It makes it harder. If the patient cannot understand, so you have to show IC materials. Later on I will take the class about the IC. Okay, যেমন পোস্টার, চার্ট দেখিয়ে বলবে। ব্যারিয়ার্স অফ কমিউনিকেশনস, কী কী ব্যারিয়ার হতে পারে? কমিউনিকেশন ব্যারিয়ার, টাইম ইজ ওভার। ওকে, ফিজিক্যাল ব্যারিয়ার টু নন ভার্বাল কমিউনিকেশনস, ঠিক আছে? তুমি গেস্টার বসে দেখাচ্ছ, পেশেন্ট ইজ ব্লাইন্ড, ব্যারিয়ার। তুমি বলছো, সে কালা, শুনতে পায় না। পারসেপচুয়াল ব্যারিয়ার, হোয়াট ইউ পারসিভ, পেশেন্ট ক্যানট পারসিভ ইট। ল্যাঙ্গুয়েজ ব্যারিয়ার, তুমি একজন হিন্দিভাষীর কাছে গেছো, ইউ অ্যাজ এ পেশেন্ট, হিন্দিভাষী বা ইংলিশভাষী, সে জানে না বাংলা, আর তুমি বাংলা ছাড়া কিছুই বুঝতে জানছো না, ল্যাঙ্গুয়েজ ব্যারিয়ার। কালচার, ও তার কালচারের কথা বলছে, কালচার ইজ ওয়ে অফ লাইফ, আমরা যেভাবে বড় হচ্ছি দ্যাট ইজ কল কালচার, ঠিক আছে? খাওয়া থেকে আরম্ভ করে, ধরো তুমি কালচারে আছে, আমার কালচারে আছে আই এম নিরামিষ, ঠিক আছে? আমি আমিষ খাই না, সে কিন্তু প্রোটিনের কথা বলতে গিয়ে মাছ, মাংস, ডিমের কথাই বলছে। ওকে, আমি কিন্তু ভেজ। সো হি শুড আস্ক ইউ অ্যাবাউট ইউর ডায়েট প্যাটার্ন, ইজ ইটস, দেন অনলি অ্যাডভাইস ইউ। সো কালচার ইজ ভেরি ইম্পর্টেন্ট। ওটা বদার করলো না, মাছ, মাংস, ডিম খাবে, প্রোটিন, হাই প্রোটিন ডায়েট খায়, ডায়েট মাছ, মাংস, ডিম এসব বললো। ছানাও বলছে না, সোয়াবিনও বলছে না, আর পনিরও বলছে না। তুমি তো ওগুলো খাও না, তুমি সিটিয়ে বসে আছো ভয়ে, ডাক্তারবাবু বলছে, তুমি খাবেও না, তোমার কোনো প্রবলেম সলভ হবে না। ওকে, সাইকোলজিক্যাল ব্যারিয়ার্স, সিমেন্টিক ব্যারিয়ার্স, রং ওয়ার্ডসে চুজ করতে, ওয়ার্ডের মানে বোঝো না। ইমোশনাল ব্যারিয়ার্স, অ্যাটিটিউডাল ব্যারিয়ার্স, অ্যান্ড লাস্ট ওয়ান ইজ জেন্ডার ব্যারিয়ার্স, বাট স্টিল ইট শুড নট বি। ওকে, সো দিজ আর দ্য কমিউনিকেশন ব্যারিয়ার্স। অ্যান্ড নেক্সট, হাউ টু ওভারকাম the barriers. Apart from all these skills, what skills I told you? Core skill 4-5, 4 to 5. Number one is, first one is active listening. First one is active listening, paraphrasing, mirroring, questioning. Okay, clear? So these are core skills of communication. Last one is summarizing. I did not tell you summarizing. Whenever you tell the patients, at last you have to summarize. তার মাধ্যমে তুমি বলবে these are the bullet points, key message that the patient should carry. Okay. এছাড়াও apart from all the communication skills, how to overcome, check whether the time is good for you as well as patients. Then only you will give the appointment, time appointment, except emergency. If patients is in emergency conditions, so we have to see about your time. Be clear and use language verbatim that the patient can understand. That is very important. Communicate one thing at a time. একসঙ্গে বড় বড় বলছো, তুমি ভেবে নিচ্ছ পেশেন্টস তো বুদ্ধিমান আছে, পেশেন্টস ইন্টেলিজেন্ট, পেশেন্টস কোয়ালিফিকেশন ভালো, সব বুঝতে পারবে। নো, টেল ওয়ান থিংস অ্যাট এ টাইম। রেসপেক্ট এ পেশেন্টস ডিজায়ার নট টু কমিউনিকেট। পেশেন্ট বলতে চাইছে না আজকে, ছাড়ো, নেক্সট আবার একদিন অ্যাপয়েন্টমেন্ট দাও, সেদিনকে আসুক। চেক দি পেশেন্টস হ্যাজ আন্ডারস্টুড ইউ কারেক্টলি। লাস্টে কোশ্চেনিং আবার করে জিজ্ঞেস করবে পেশেন্ট, হোয়াট আই টোল্ড ইউ অ্যাজ এ ডক্টর, whether the patient has understood everything or not. Acknowledge any emotional responses the patient has to what you as a doctors have said. হয়তো এমন কথা বললে লাস্টে উইপিং কান্তি আরম্ভ করলো, এরকম চলবে না, তাহলে তোমার কিন্তু কমিউনিকেশন ঠিক হবে না, ডায়াগনোসিস ঠিক হবে না, ট্রিটমেন্ট ভুল হবে। ডু নট মেক এনি জাজমেন্ট, দ্যাট ইজ ভেরি ইম্পর্টেন্ট। ইউ মাস্ট বি হ্যাভিং নন জাজমেন্টাল অ্যাটিটিউড। অ্যানাদার ওয়ান I will tell you, that is called, last I will finish it by writing this one, non-judgmental one is, you must be non-judgmental, means preconceived notion থাকবে না, এ খারাপ এ ভালো, no, all are equal. As a patient, a person has come to you to treat, you have to treat as a normal human being. And last one is empathy. What is the meaning of empathy, not sympathy? আরে কত কষ্ট আপনার সবসময় বললে হবে না, you have to show empathy. What is the meaning of empathy? What is the meaning of empathy? Very important word. As a doctor, it is very important for you people to know, practice. Empathy means put yourselves in the position of the patients and think, if I would have been as a patient, what would have been my conditions? As a patient তুমি চিন্তা করবে, আমি এখন পেশেন্টস, আমি পেশেন্টস হলে আমার মনের অবস্থা কী হতো, ঠিক সেইভাবে তোমাকে শুরু করতে হবে। ওকে, 1 minute more I will take to ask questions for clarifications. Any questions regarding communication skills? Demonstrations, lean forward, okay, like this, active listening, that is very important. Okay, thank you very much.
So here at cardiovascular and in previous two classes we have talked about the normal ECG complex, right? The normal waveform and of ECG complex and the basic physiological features of their temperature, right? Okay. So we in an ECG complex, say for example in P wave signifies atrial depolarization, right? QRS complex signifies ventricular depolarization, and E wave signifies ventricular repolarization. And we do not see atrial depolarization because atrial depolarization is buried under or covered under QRS complex, right? So this is the sequence in the ECG. This is the sequence in the ECG: atrial depolarization, followed by ventricular depolarization, followed by ventricular repolarization. Okay, and you already know that depolarization actually charges the cavity, for example, the ventricle, and once the ventricle is depolarized or the ventricle is charged enough, it contracts, it goes into systole, right? So depolarization will cause systole and depolarization will cause diastole, right? Okay. Now there is a term called PR interval, right? There is a term called PR interval. PR interval is from the beginning of P wave, up to start of QRS complex. So remember, it is not PQ, it is PR. Even if the duration is from the start of P wave up to beginning of QRS complex, it is called as PR interval and not PQ interval, right? So it is PR interval. Its duration is PR interval, and as you know, PR interval limit is up to 0.2 seconds. 0.2 seconds, that is maximum 5 small squares. Maximum 5 small squares, because 1 small square, the duration is 0.04 seconds, right? So in the x-axis, in an ECG, X-axis is time and Y-axis is voltage, right? And in the ECG graph paper, one small square is equivalent to 0.04 seconds, and this one is 0.1 millivolt. Okay, so Y value one small square equals to 0.1 millivolt, and Y value one small square equals to 0.04 seconds. So what you need to calculate is the number of small squares within PR interval. So this is PR interval. So say for example, we have 4 small squares in between, right? In the graph paper, we have 4 small squares in between. So 4 into 0.04, PR interval is equal to 4 into 0.04, that is 0.16 seconds. And this is normal, right? So once PR interval is more than 0.2 seconds, it is called PR interval is prolonged, right? PR interval is prolonged. Okay. So today's topic is heart block and coordination, right? That is coordination. Now another thing in ECG is the ST segment. What is ST segment? This one is ST segment, right? This one is ST segment. So if I ask you what is the voltage of ST segment? What is the net voltage of ST segment? Net voltage is 0 because ST segment is isoelectric line. ST segment is isoelectric line. This is the base line, right? This one is the base line. This one is the base line of ECG, right? This one is the base line of ECG. Okay. So if I ask you what is the voltage of R wave, if I ask you what is the voltage of R wave, what you will do? You will calculate the number of small squares. Okay, number of small squares. 1, 2, 3, 4, 5, 6, 7, and 8. Right? So from the baseline, the height of R wave is 8 small squares. And you know, 1 small square is equal to 0.1 millivolt. Right? So height of R wave is 8 into 0.1 is equal to 0.8 millivolt. Right? So this is how in an ECG we can calculate the voltage of each wave. If I ask you what is the voltage of each wave, similarly calculate it downwards. Right? And say for example it is minus 0.9 millivolt. Right? In this way. Okay? So you can calculate the voltage of individual wave and also you can calculate the duration. Say for example PR interval. Starting from P wave to beginning of Q wave. This is PR interval. And we have 4 small spaces in between. That means PR interval is 4 into 0.02, that is 0.16 seconds. Right? And the normal range of PR interval is up to 0.2. 0.1 to 0.12 to 0.2 seconds. This is normal PR interval. Right? Once PR interval is beyond that, more than 0.2 seconds, we call it first degree heart block. Right? We call it heart block. Okay, I am coming to heart block in subsequent slides. Next, QT interval. QT interval is from the beginning of Q wave up to the end of Q wave. Okay, so this is QT interval. Again, how to calculate QT interval? You need to calculate the number of small squares in between. Let us see an ECG so that okay. So see this ECG, right? You see this ECG. So small squares, very small squares. Okay, not this one, okay. Ekdam small square, right? So the smallest square here is this. Horizontal is 0.04 second and vertical is 0.1 millivolt, right? So here you have, say for example, this lead to this lead to, this is the P wave, this is Q wave, this is R wave, this is S, and this one is T wave, right? So if you were to calculate PR interval, so you start from this point and up to this beginning of Q, right? So you will calculate the number of, right? So say for example, number of small square is 3 small squares. So PR interval will be 3 into 0.04, that is 0.12 second, and it is normal. Okay. So here QT interval is from the beginning of Q wave up to end of T wave, right? From the beginning of interval. Again, you calculate number of small squares in the QT interval. Okay. So say for example, a total 10 small squares. Okay, 10 small squares. So in QT interval is 10 into 0.04 is equal to 0.4, right? 0.4 second, that is 400 millisecond, and this is normal, right? QT interval is up to 550 millisecond, right? Okay. So in your examination, you will be given an ECG strip, you will be given an ECG recording of a patient or maybe of a normal healthy individual, right? And you are to calculate the PR interval, you are to calculate the voltage of R wave, you are to calculate the QT interval, you are to comment on the ST segment, right? Okay. So this is how exams goes on. So now another part is ST segment. What is ST segment? So ST segment is an isoelectric line. Okay. So this is ST segment. So you see there is no voltage in ST segment. This is baseline, right? This is baseline. So this is ST segment, and ideally ST segment should be an isoelectric line. Okay. If ST segment is not isoelectric, say for example, ST segment is this, right? Maybe ST segment is this, we call it ST segment elevation. Okay, ST segment elevation. Okay. It can be right, and this is the line. Let me draw this line. So this is ST segment elevation and this is ST segment depression. Okay, ST segment elevation and ST segment depressions are not normal, right? So most commonly and usually ST segment changes in ST segment elevation or ST segment depression, they signifies a coronary syndrome. In layman terms, heart attack, right? Okay. So from your ECG classes, you should be competent enough to identify a case of heart block, to identify a case of acute coronary syndrome. So let us start with acute coronary syndrome. Okay, acute coronary syndrome is an umbrella diagnosis. Okay, umbrella diagnosis means इसके अंदर बहुत सारे diagnosis है, right? So acute coronary syndrome, I'm coming to okay. So there is a slight pathophysiology of acute coronary syndrome, how acute coronary syndrome occurs in a patient or how heart attack occurs in a patient, right? So now onwards do not use a term like heart attack, it is a layman term. So actual term is ACS, acute coronary syndrome, right? Acute coronary syndrome. So what is the pathophysiology of acute coronary syndrome? How does it occur, right? So plaque disruption or erosion, thrombus formation, you know what is thrombus, right? A clot, blood clot, right? So thrombus formation, acute cardiac ischemia. What happens? Small thrombus, they get dislodged and they are stuck into the finest coronary arteries, and that disrupts coronary arterial circulation, right? They disrupt coronary arterial circulation. As a result, your myocardium or cardiac muscle suffers from ischemia. Ischemia means lack of blood supply, and as a result of ischemia, when there is cell death, it is called infarction. Cell death is infarction, and when the cell is suffering from low blood supply, inadequate blood supply, it is called ischemia. Okay, acute coronary syndrome, it is also called ischemic heart disease, right? IHD or ischemic heart disease, right? Okay, so thrombus formation, acute cardiac ischemia. Now you will perform an ECG. Okay, patient will be complaining of severe chest pain. Chest pain may be radiating towards back, may be radiating towards the left arm, right? So these are likely symptoms a patient will be suffering from, right? So maybe at midnight the patient will be coming to the hospital with complaint of acute chest pain, tightness in the chest, right? Tightness in the chest, breathing difficulty, sweating. So these are the symptoms. And chest pain may radiate to back, may radiate to left inner arm, right? These are the symptoms. So you are at the emergency, you are an emergency doctor, how to handle it? Immediately you will perform an ECG, right? Which is a very quick evaluation for cardiac status, right? So you will perform an ECG. So you may get ST segment elevation. Let us discuss first. So you may get ST segment elevation, okay, and elevated biomarkers of myocardial necrosis. Okay, so what are the biomarkers of myocardial necrosis? So when myocardial cell is damaged, the content within the cell will come out into the blood, and you can detect the serum level of those biomarkers. Say for example LDH, say for example troponin, right? Say for example CPK, right? Creatine phosphokinase. So these are within myocardial cells, but when the myocardial cell is damaged, the content within the cell, these enzymes will leak out into the blood, and you can just simply do a blood test to detect CKMB, to detect troponin, and nowadays it comes as a kit, okay. So you can use the kit, you can drop patient's blood and you get the test result immediately, whether it is positive for troponin or not, okay. Troponin T is very frequently used, it is called TROP-T test, TROP-T, right, troponin T. So when troponin T test is positive, that means biomarkers positive, that means there is definitive damage within the myocardial cell, myocardial cells are damaged. Troponin is inside the myocardium, right, inside the cell, inside the cardiac muscle cell. Now cardiac muscle cell is damaged and troponin T is leaking into the blood, and you are detecting by simply doing a blood test, right, okay. So you have a patient of chest pain, complaining of chest pain, breathing difficulty, pain is radiating towards back or maybe left side of the arm, right. You have done an ECG, you got elevated biomarkers of myocardial necrosis like troponin T and also ST elevation, ST segment elevation. Normally ST segment should be isoelectric, but in your case ST segment is elevated, right. So you stamp the diagnosis with ST segment elevated myocardial infarction, right. So we call it STE. Okay, what is STEMI? STEMI is ST segment elevation myocardial infarction. Okay, frequently you will be going to whenever you will be going to ward, you will see, or ICUs, you will be seeing patients that nurses or doctors, they are calling this patient is STEMI, this patient is NSTEMI. So STEMI is ST segment elevation myocardial infarction, right? Okay. Now another segment is non-ST segment elevated myocardial infarction. So by now you know that whenever the patient is having attack or heart attack, right, acute coronary syndrome, the patient will be having ST segment elevation. And yes, most of the cases it is true, but there are cases when ST segment, the patient will be having myocardial infarction or acute coronary syndrome, but the patient will not be having ST segment elevation, right. We call it NSTEMI, non-ST segment elevation myocardial infarction. So how to diagnose a case of NSTEMI, non-ST segment? The patient is having problem, there is some problem in the coronary artery, but still ST segment is not elevated. It might happen, right. Although major percentage is this ST segment elevated myocardial infarction, right? ST segment elevated myocardial infarction. This will be the major cases, right? Say for example 80%, but remaining 20% you need to diagnose as well, right? So remaining 20% will be non-ST segment elevated myocardial infarction. So from ECG you can diagnose almost, right? So non-ST segment elevation myocardial infarction, you perform the biomarkers like troponin T, okay. In few cases it will be positive, right, biomarkers positive, and you call it non-ST segment elevation myocardial infarction. And sometimes due to coronary artery spasm, what happens, biomarkers are also not elevated, okay. In ECG there is no ST segment elevation and also biomarkers are also negative, okay. We call it unstable angina, okay. we call it unstable angina. So, under acute coronary syndrome, you have three major diagnoses. One is unstable angina, another is non-ST segment elevated myocardial infarction, and the third and most important is ST segment elevated myocardial infarction, STEMI. Okay, unstable angina, UA, NSTEMI and STEMI. Unstable angina, NSTEMI and STEMI. Okay. Okay, you will study more details on acute coronary syndrome and their diagnosis, their treatment in final year while in medicine, general medicine. But now you need to know the pathophysiology of the disease, right? So, we are here at acute coronary syndrome, and acute coronary syndrome patients in an ECG, again we are focusing on ECG because the class is on ECG, right? So, in acute coronary syndrome, the patient might be having ST segment elevation or there might be ST segment depression, right? ST segment elevation or ST segment depression. Now, in physiology, the teacher will ask you why there is ST segment elevation, why there is ST segment depression. This is the thing you need to know, the background, why there will be ST segment elevation in a case of acute coronary syndrome, right? So, let us focus. Okay, see this. So, can you tell me during ST segment, which is ideally an isoelectric line, during ST segment, the heart is in systole or diastole? What? It is written here, dekh ke to batao. It is in systole, right? So, this is QRS and this is T. The whole duration we have also plotted the action potential, cardiac action potential, right? So, within this cardiac action potential, this duration must be systole, this duration is systole, right? This duration is systole, right? And this duration is systole, ST segment. This is ST segment is actually the play-2 phase, right? So, this is your myocardial action. This is the play-2 phase. Voltage change. During this time there is voltage change, but during there is no voltage change, right? It is called play-2 phase, phase 2 of myocardial action potential due to long lasting calcium channels and potassium channels, right? So, during this play-2 phase what happens? It corresponds with the ST segments in ECG, right? Okay. Now, what happens in case of ischemic cell? Okay. So, this black one, this black action potential, this black colored action potential is of normal heart tissue, normal heart, right? Normal heart tissue. And what happens in an ischemic tissue? An ischemic tissue is this one, red one. Okay. So, what is the difference between action potential of a normal myocardium and an injured myocardium, damaged due to ischemia? Okay. So, the difference is during diastole, that is phase 4 of the action potential. If you have not studied action potential yet, you will not be able to understand, and that is not my fault, right? Okay. So, during phase 4, what happens to ischemic tissue? During phase 4, you see the ischemic tissue is towards positive. Okay. During phase 4 means resting membrane potential, it is at minus 90 millivolt, right? It is at minus 90 millivolt, but once the tissue is ischemic, phase 4 is at minus 60 millivolt, right? Phase 4 is at minus 60 millivolt, but it is reversed during systole. So, during diastole, voltage is towards positivity in case of ischemic tissue, and during systole, it is down. Okay. तो यहाँ पर देखो during diastole what happens, black line नीचे है और red line ऊपर है, right? And during systole what is happening, just reverse, black line ऊपर है, red line नीचे है, right? So, during diastole, ischemic tissue is more depolarized, it's less negative, and during diastole, ischemic tissue is more repolarized, मतलब more negative, right? This is what happening, and you know that electricity will flow from positive to negative, right? Electricity will flow from positive to negative. So, that means during diastole, electricity will flow from ischemic tissue to normal tissue. During diastole, electricity will flow, matlab vector. During diastole, electricity will flow from ischemic tissue to normal tissue, and during systole, electricity will flow from normal to ischemic tissue. Clear? Normal to ischemic tissue. It will be clear in the next slide. Yes. So, you see in next slide, diastolic vector, during diastole, electricity is flowing from ischemic tissue to normal tissue, and during systole, electricity is flowing from normal tissue to ischemic tissue, right? Normal tissue to ischemic tissue. Okay. Next slide. Next slide. Okay. See this. Now, there are two types of injury in the ventricular wall. There are two types of injury. One is transmural. Okay. Transmural means throughout the thickness of the ventricular wall. See this. Okay. Transmural or epicardial. It is throughout the thickness of ventricular wall. Throughout the thickness of ventricular wall. Okay. Ventricular wall ta jotota mota, total ta ischemic hoye geche, total ta injury hoye geche, right? The inner side is spared. Inner side is little bit spared because this cavity is containing blood. Okay, this cavity is containing blood, and the myocardium nearest to the cavity, it gets some oxygenation from this blood, right? So, this is the left ventricular, this is left ventricular wall, left ventricular free wall, and the red area is ischemic. Red area is not getting adequate blood supply, right? So, this red area is ischemic or necrotic, whatever, ischemic. So, what is happening? Electricity is flowing from the normal tissue towards ischemic tissue, normal tissue towards ischemic tissue, right? Normal tissue towards ischemic tissue. Okay, during systole, normal tissue towards ischemic tissue, and here you see this is subendocardial injury. Subendocardial injury, matlab injury is towards the cavity, right? Injury is towards the left ventricular cavity. Now electricity is again flowing from normal tissue to ischemic tissue, normal tissue to ischemic tissue, but the directions are different. Directions are different. So, what will happen in case of transmural injury? As the electricity is flowing, that means depolarization vector is moving in this way during ST segment. Okay, during ST segment, during systole. So, during systole, it is the vector or electricity is moving in this direction. In this direction is, you know, what lead is there? What lead is there? In this degree, what lead? Lead 2, right? In this direction, lead 2. So see, lead 2 or V5. Okay, V5 is also in this direction, right? So here the example is with V5. So you see V5 electrode is there. So in case of transmural injury, electricity is flowing towards lead 5, towards V5, and here electricity is flowing opposite to lead 5. That means there will be ST depression, and in this way, in this transmural injury, electricity is flowing towards lead. And you know, this is much more dangerous because this is transmural. The whole thickness of the myocardium is damaged. This is much more dangerous. Definitely you will get an ST segment elevation, and this is an emergency. Immediately you need to treat the patient with aspirin, with clopidogrel, with oxygenation, with morphine, and if possible, percutaneous vascular approach, right? And that is usually done in tertiary care hospitals, right? So it is an emergency. It is an emergency. You need to treat the patient immediately, either with thrombolysis or with PTCA, matlab percutaneous angioplasty, right? Okay. So next slide. Okay. Now, how to identify the wall involved? How to identify the wall involved? Okay. So here it is a case of acute inferior wall ST segment myocardial infarction. So what do you see? You see ST segment elevation in lead 2, right? You see ST segment elevation, this is the baseline and ST segment is elevated. This is the baseline and ST segment is elevated, right? Lead 2. Now see lead 3, again ST segment is elevated. Lead V5, F5, AVF. Okay. Lead AVF, again you see ST segment is elevated. Okay. So ST segment elevated is there in lead 2, 3 and AVF. It is a case of acute inferior wall myocardial infarction. Okay, so patient is coming to you with severe chest pain. You perform this ECG, you see this ECG and this is an emergency. You immediately treat the patient or use life, right? Okay. Now, how to identify whether it is inferior wall or anterior wall or lateral wall or apical wall, whatever, right? So, how to identify? Okay, so this is lead 1, this is lead 2, this is lead 3, this is lead AVF, AVF 2, 1, 3, AVL and AVR, right? Now 2, 3 AVF, these 3 leads are inferior wall. Okay, so when heart's inferior wall, okay, you can assume heart as a structure which has got a base, apex, inferior wall, anterior wall and lateral wall, right. So, when 2, 3 AVF, these 3 leads are involved. You see 2, 3 AVF, 2, 3 AVF, these 3 leads are characterized by ST segment elevation, right. So, it is a case of acute inferior wall myocardial infarction, right. So, inferior wall right, lateral wall V5, V6, 1, right, anterior wall septal V3, V4, correct. So, if you see ST segment elevation in lead 2, 3 AVF, it is inferior wall myocardial infarction. If you see ST segment elevation in 1 AVL, V5, V6, it is a case of acute lateral wall myocardial infarction. And if you see V1, V2, it is anterior wall myocardial infarction. If you see V3, V4, it is septal myocardial infarction, right. And most of the time it is combined. You may see anterolateral myocardial infarction, you may see anteroseptal myocardial infarction, okay, in this way. Next slide. Okay, see this. What do you see? What do you see? Again, another example 2, 3 AVF. 2, 3 AVF, you see ST segment elevation myocardial infarction. So, it is a case of inferior wall myocardial infarction. Next slide. Okay, okay, see this. Do you see any abnormality here? Do you see any abnormality here? Okay, you can't see any ST segment elevation over here, but you see T wave inversion, right? You see T wave inversion here, T wave inversion here, here in AVF T wave inversion, right? So, 3 AVF you see T wave inversion. T wave inversion is a subsequent thing in myocardial infarction, right? So, it depends on timing. Why I am telling that it is a medical emergency, the patient is suffering from acute coronary syndrome, STEMI, ST segment elevation myocardial infarction. So, if you perform a serial ECG on the patient, you will gradually lose ST segment elevation, right. So, one history is definitely important for you. You may need to, you must ask the patient कि पेन कब से स्टार्ट हुआ था, पेन कখন शुरू होएছে, ठीक है. If the patient arrives to you within 2 hours, within 3 hours, you may see ST segment elevation. Even at 6 hours, you may see ST segment elevation. কিন্তু পেশেন্ট যদি বলে গতকাল থেকে আমার বুকে ব্যথা করছিল, you may not see ST segment elevation, right? So, ST segment elevation will gradually normalize and there will be T wave inversion and it will prevail, right? So, depends on the presenting point of the patient. Patient কখন আসছে, right? And the sequence goes like this. There will be ST segment elevation, hyperacute Q wave, then T wave inversion, ST segment normalization, and T inversion will remain, right? In this way it progress, right? Okay. Anyway, these are thoda sa higher level. Okay, next slide. Okay, this is old inferior wall myocardial infarction. If you see old inferior wall myocardial infarction, you don't see any ST segment elevation over here, rather you see 2, 3 AVF, you see T wave is inverted, T wave ulta hai, right? T wave is inversion. So you see T wave inversion here. So you don't see T wave upright, you see T wave downwards, right? Downwards T wave. This is T wave inversion. In AVF again T wave inversion, in 2 lead to again T wave inversion, right? So it is a case of old myocardial infarction, old inferior wall myocardial infarction. Okay, next slide, next. Okay, move on. बाकी जो ECGs है हम लोग प्रैक्टिकल में आपको पढ़ाएंगे. Next. This is आगे slide. This is a case of unstable angina, right? This is a case of unstable angina. You see ST segment depression over here. ST segment depression. I know most of you guys are not understanding adequately because it is a matter of practice. Until and unless you see 100 patients ECG, you will not have an adequate idea to diagnose the patient, right? So right now just remember the theoretical aspect, and we will show you ECGs in practical classes, and also you can search Google for multiple ECGs. If you search anterior wall myocardial infarction, you will get hundreds of ECGs, right? You just see them and try to interpret them. If you search in the Google inferior wall myocardial infarction, you will get again thousands of ECGs. You study them, right? So until and unless you see at least hundreds of ECG, your eyes will not be adapted which ECG is what, right? Which ECG is what type of ST segment elevation myocardial infarction. Okay, diagnosing ST segment elevated myocardial infarction is very often challenging, right? Very often challenging, but the easy ones, you need to diagnose the easy ones, right? And not only diagnosing, you need to identify which wall of the myocardium is involved, whether it is anterior wall or inferior wall or posterior wall, right? Or septal wall, right? Okay. Okay, I guess the theoretical background is clear to you, why there is ST segment elevation and why there is ST segment depression. So grossly, if it is transmural, the whole thickness of the myocardium is damaged or ischemic, there will be ST segment elevation. And if it is subendocardial, okay, only part of the myocardial thickness is involved, there will be ST segment depression, right? But both are abnormal, whether it is ST segment elevation or ST segment depression, both are abnormal. Okay, it is not supposed to happen in a healthy resting individual, it is not supposed to happen, right? Okay, next slide. Okay, next we have already covered acute coronary syndrome. Whatever is required for you, acute coronary syndrome is a big thing, is a big chapter in in medicine, right? Okay, you will study acute coronary syndrome in pathology as well, right? In pharmacology as well, in medicine as well. So you will keep on studying on acute coronary syndrome. So these are the basics of not basic, I have told few details also, right? So for your level, acute coronary syndrome is over, right? Again, in ECG practical classes, we will show you some ECGs of acute coronary syndrome, and you may need to identify those things during your examinations, right? Okay, now heart block. What is heart block? Heart block is basically, we are starting with AV block, okay? AV block, atrioventricular block. Okay, do you know there is the depolarization wave which is traveling from your SA node. The depolarization wave which is traveling from your SA node, right? It travels through AV node, right? It travels through AV node and then his Purkinje system, right? His Purkinje system. So AV node, after AV node we have bundle of His, then bundle of His divides into the right bundle branch and the left bundle branch, right? Right bundle branch and the left bundle branch. Left bundle branch divides into anterior fascicle and posterior fascicle, right? So this is the conduction system in heart looks like, right? Do you know what is the function of AV node? What is the function of AV node? Yes? Pace checker or pacemaker, what? Okay, so it is actually a policeman, right? It is actually a policeman. It is checking the wave which are coming from the atria, right? Which are coming from the atria, okay? this is your SA node. This is branch, the left bundle. It has got anterior fascicle and a posterior fascicle, right? This is how it looks like, right? This is right bundle branch. This anterior fascicle, posterior. This is the conduction system in heart. What do you mean by conduction system? Conduction system means it is carrying what? It is carrying what? What? Blood? No, not blood. Impulse. What impulse? Electrical impulse. Okay, so SA node is this electrical impulse action potential. So your SA node is generating action potential. SA node is generating action potential. This action potential is traveling in this pathway. Okay, and I have told you in previous classes that what is the requirement of this conduction tissues, because your heart, your cardiac muscle is already capable of transmitting these electrical impulses. Okay, even without this conduction system, your heart is capable of conducting impulse from one myocyte to another myocyte. The electrical impulse can travel from one myocyte to another myocyte even without the presence of this conduction system. Then what is the requirement of this conduction system? What? If you depolarize one myocardium, it will depolarize all the neighboring myocardium. So electricity can travel without this conduction system. Then what is the utility of this conduction system? Faster. Okay. From one myocardium to another myocardium, how electricity travels? What is the hardware? कुछ तो चाहिए, एक मायोकार्डियम से दूसरे मायोकार्डियम में इलेक्ट्रिसिटी फैलने के लिए क्या चाहिए? What is the connection between two cells? Gap junction. Yes, the connection is gap junction through which electricity travels from one myocardium to another myocardium. If one myocardium is depolarized, the neighboring myocardium, all the myocardium is depolarized. Okay. I had given example of bricks. Okay, this wall is made up of bricks, right? So if you depolarize one brick, all the bricks will be depolarized. Okay, पूरा घर current हो जाएगा, right? Okay. So if one myocardium is depolarized, the neighboring myocardium will get depolarized. But what is the utility of this conducting tissue? The conducting tissue is nothing but a specialized myocardium where there are millions of gap junctions, right? So they can transmit electricity faster, right? Faster from SA node to AP node, from AP node to bundle of His, from bundle of His to all the ventricular walls, right? So the purpose of having a good conducting tissue is to transmit the impulse faster, right? Okay. Now your is a policeman, checkpoint. Your AV node is a policeman, checkpoint. It will allow only the impulses which are coming from AV node. It will check whether the impulse is coming from SA node or not. If it is not coming from SA node, I will not allow to go into the ventricle, because ventricle is so much sophisticated. I will not allow any abnormal impulse to travel into the ventricle from the atria, right? There are abnormal focus. There might be due to disease process, due to many disease process like acute coronary syndrome, right? Due to many disease process, there are generation of ectopic foci which can generate impulse and may act like pacemaker tissue, although they are not actually pacemaker tissue, right? The authorized pacemaker tissue is only SA node, right? But sometimes due to disease process, many ectopic focus may discharge or may act like pacemaker tissue, right? But we will allow only the impulses which are, right? We will allow only the signals which are coming from SA node. So these are ectopic focus. They can also send signal to AV node. Will check whether the signal is coming from SA node or not. If it is coming from SA node, I will allow to go into the ventricle. Otherwise, I will block it, right? So this is how your AV node is protecting your ventricle from getting any abnormal depolarization, right? But there are situations when the AV node loses its function due to disease process, due to any disease process, right? Okay. And there might be two things. One is abnormal delay in reaching SA nodal signal to ventricle, abnormal delay, or there might be extra signal coming to the ventricle other than that which is appearing from the SA node, right? So, there might be two things when your AV node is somehow diseased, right? Your AV node is somehow diseased. Your AV node is checking abnormal impulses coming from atria to ventricle, right? So, if AV node is not working properly, it may allow abnormal impulse into the ventricle, that may give rise to arrhythmia. That is a different class I will take in subsequent classes, right? Another thing is AV node is not at all allowing any signal coming from the atria, right? So, abnormal delay in reaching the depolarization wave from atria to ventricle, okay, which is heart block, atrioventricular block, AV block, right. Okay, so, what is happening in AV block? Next slide. Next slide. So, first degree heart block, what I told in first degree heart block, PR interval, simply calculate PR interval. PR interval is from the beginning of P wave up to the generation of Q wave, up to the beginning of Q wave. So, it is not PQ, we call it PR. Remember, it is not PQ, we call it PR. So, just calculate PR interval. So, PR interval is 360 millisecond here. This is P wave and this is Q wave. This is P wave, this is Q wave. So, PR interval is abnormally prolonged. Abnormally prolonged. There are 9 small squares. There are 9 small squares within the PR interval. So, 9 into 0.04, that is 0.36 second. 0.36 second is equal to 360 millisecond. So, which is abnormally high, and we call it first degree heart block, right. So, this is a case of first degree heart block, and you need to identify this as a first year MBBS student. You need to identify first degree heart block. What will you do? Simply calculate the PR interval. If it is more than 0.2 second, that means if it is more than 5 small squares, it is abnormally high. So, it is a first degree heart block. So, everywhere you see PR interval is prolonged. PR interval is prolonged and fixed. Everywhere it is 360 millisecond or 0.36 second, right. So, it is a case of first degree heart block. What will be the patient's symptom? What will be your treatment? Nothing. So, first degree heart block is a benign thing. Patient will not die out of it, right. Even if you diagnose first degree heart block, there is no need for treatment. There is no need for treatment. First degree heart block is usually asymptomatic. Patient will not be having any symptoms, and if the patient is not having any symptoms, there is no need of treatment, right. So, first degree heart block is asymptomatic. Even if it is diagnosed, it is left as such. There is no requirement of any treatment, right. So, it is first degree heart block. Next slide. Okay, coming to it later on. Next slide. Next. Second degree heart block. Second degree heart block, Wenke-Back or Mobis type 1. What is second degree heart block? So, second degree heart block, you see the PR interval. PR interval is gradually increasing. It is 260 millisecond in the previous complex. Now, it is 280, 260, 280, 320. So, PR interval is gradually increasing until a point where P wave is not followed by a QRS complex, right. So, in a normal ECG wave, P wave is always characterized by a subsequent QRS complex. P wave के बाद एक right, okay. So, you see P wave here and a QRS complex, P wave here and a QRS complex, P wave here and a QRS complex, P wave here, no QRS complex. Okay, so your PR interval is increasing and suddenly P wave is not followed by a QRS complex. Okay, so P wave PR interval keeps on increasing until there is a drop, there is no QRS complex, right. It is called second degree heart block Mobis type 1. Next slide. Okay, second degree block Mobis type 1, the previous slide. Mobis type 1 is again asymptomatic, and usually we do not need any treatment for that. Now, second degree heart block, Mobis type 2. Okay, so in Mobis type 2, what happens? This is much more dangerous than Mobis type 1 because it needs treatment and it needs follow up, right. and it might lead to complete heart block, right? It might lead to complete heart block when there will be requirement of pacemaker insertion, right? Okay, so what is happening in second degree heart block or Mobius type 2 second degree heart block? Okay, so here you see PR interval is prolonged. Yes, PR interval is prolonged, definitely PR interval is prolonged, but it is not gradually increasing. It is more, yes, PR interval is prolonged, but it is fixed. But still there is a drop. Okay, still there is a drop. Okay, this P wave is followed by QRS complex, this P wave followed by QRS complex, this P wave followed by QRS complex, this P wave is not followed by QRS complex. So PR interval is not gradually increasing, it is fixed, but still there is a drop bit, right? Okay, so this is second degree heart block, and this is much more dangerous than first degree heart block because it may anytime may lead to complete heart block. Next slide for complete heart block. Next slide, next slide, next slide, next slide. Yes, third degree heart block or complete heart block. So up to second degree heart block, there was a relation between P wave and QRS complex. There was a relation between P wave and QRS complex, but in case of third degree heart block, there is complete atrioventricular dissociation. What is atrioventricular dissociation? P wave is beating on its own, QRS complex is beating on its own. ठीक है, हस्बैंड वाइफ में झगड़ा हो गया, दोनों अपने तरफ, मतलब atria is generating P wave अपने आप, and ventricle is generating its own wave. There is no relation between P wave and QRS complex. Normally what happens, atria generates P wave and that signal comes to ventricle, then ventricle generates QRS complex, right? So this is a synchrony, and this synchrony is totally lost. Okay, atria is beating on its own and ventricle is beating on its own. ठीक है, कोई किसी को नहीं देख रहा है. Atria is beating on its own, ventricle is beating on its own. So there is absolutely no relation between P wave and QRS complex. Absolutely, there is no relation between P wave and QRS complex. You see, P wave is coming anywhere. So here is the P wave and here is the QRS complex, right? Here is the P wave, right? Here is the P wave, but QRS complex is here. Here is the P wave, QRS complex is here. Okay, so absolutely there is no relation between P wave and QRS complex. Sometimes P wave is falling before QRS complex, sometimes P wave is falling after QRS complex, sometimes P wave is within QRS complex, sometimes P wave is within the T wave, right? So many things are happening. Okay, so it is completely a bizarre event, right? Completely a bizarre haphazard event. Okay, atria is beating on its own, ventricle is beating on its own, and this is this type of beating of heart is absolutely of no use, right? Because heart is not able to pump adequately in case of complete heart block, and this is a definitive indication of insertion of pacemaker, right? Next. Okay. Now another thing is, we have discussed acute coronary syndrome, ECGs in acute coronary syndrome, ECGs in heart block, and particularly AV block. Now another type of block, that is bundle branch block. What is bundle branch block? What is bundle branch block? Simple. Conduction tissues, right? This is the defect in conduction tissues. So up to this point we have talked about AV nodal block. Block यहाँ पर हो रहा था, block यहाँ पर हो रहा था, right? So now the block is here in the right bundle branch, right? Block is here. What will happen? Your right bundle branch, it depolarizes the right ventricle, and left bundle branch, it depolarizes left ventricle, right? Now once your right bundle is blocked due to any disease process, myocardial ischemia, fibrosis subsequently, right? So right bundle is blocked. What will happen? Your right ventricle will not be depolarized. ऐसा है क्या? Right ventricle will not be depolarized if I block this route. This is your ventricle. This is your ventricle, and this is the bundle branch. Your right bundle is depolarizing the right ventricle. Left branch is depolarizing the left ventricle. So what I am doing? I am blocking right ventricle. What will happen? Right ventricle will get depolarized at all or not? হবে কি হবে না? রাইট ভেন্ট্রিকল ডিপোলারাইজ হবে? কেন হবে না? কেন হবে না? Depolarize definitely হবে, because there are healthy myocardium. One myocardium can pass depolarization wave to the subsequent to the neighboring myocardium, right? But it will be slow because there is no conduction tissues. Because there is no conduction tissues, so right ventricle will be depolarized slower, right? Normally, both the ventricles are depolarized simultaneously, right? Both the ventricles are depolarized simultaneously because of the presence of conduction tissues, the right bundle branch, the left bundle branch. Now if you are blocking the right bundle branch, what will happen? It is normal, left bundle branch is normal, so your left ventricle will get depolarized faster, right? Now from one cell to another, your right ventricle will get depolarized and it will be slower. Okay, so you can differentiate depolarization of both the ventricles. पहले right ventricle depolarize होगा, फिर left ventricle depolarize होगा, फिर right ventricle depolarize होगा, right? Okay, and you can detect in ECG that it is happening. You can detect in ECG. How? So normal QRS complex is this. So depolarizing simultaneously. So you get a single wave, right? You get a single R wave. But once left your R wave is split, right? R wave is split because left ventricle पहले depolarize हो रहा है, then right ventricle depolarize हो रहा है. So you get a M pattern in the ECG. See, getting the M pattern, right? You look at V1, V2 and also in V3 you are getting M pattern, right? So this is right bundle branch block, okay? So similarly, if there is left bundle branch block, you will be getting M pattern in lead V5, V6. Next slide. See V5, V6 getting M pattern. V5, V6 M pattern. So this is left bundle branch block, right? Left bundle branch block. Okay, there is a mnemonic to remember. But later on in your remember this, because so frequently you will be seeing the cases of right bundle branch, left bundle branch block, right? So right okay, so if M pattern in V5, V6, correct? So having marrow subscription, so remember right? William marrow. What is William marrow? Right? So in case of right bundle branch block, you get M pattern in V1, V2, right? In case of V5, V6, you get M pattern in V5, V6, right? So this is V1, V2. Wait, से लिखना होगा. Bundle branch block, you get W just opposite in left bundle branch block. In left bundle branch block, you get M pattern in V1, V2 and W pattern in V5, V6, right? Clear? Okay. Next slide, next slide. Next, answer this. So, a mother informs the pediatrician that she wants to hold down her daughter during venipuncture since the girl is extremely fearful of needles. একটা বাচ্চাকে ইনজেকশন দেওয়ার আছে, ঠিক আছে? একটা বাচ্চাকে ইনজেকশন দেওয়ার আছে অ্যান্ড বাচ্চার মা বলছে যে ও ইনজেকশন দেওয়ার সময় খুব ভয় পেয়ে যায়, রাইট? When the girl sees the venipuncture needle and become anxious, which of the following circulatory beds will respond with minimum percentage decrease in blood flow compared to the pre-stimulation? ওকে, ভয় পেলে কি হয়? অ্যাংসাস হলে ভয় পেলে কি হয়? ভেসোকনস্ট্রিকশন হয়, ব্লাড ভেসেলগুলো কনস্ট্রিক্ট করে, তাই তো? আর ব্লাড ভেসেল যদি কনস্ট্রিক্ট করে তাহলে কি ব্লাড সার্কুলেশন ভালো হবে না খারাপ হবে? খারাপ হবে, ব্লাড সার্কুলেশন কম্প্রোমাইজড হবে, রাইট? So the question is asking which vascular bed is least affected? Which vascular bed is least affected? ঠিক আছে, মানে যেখানে ব্লাড সার্কুলেশন কম্প্রোমাইজড হবে না, which vascular bed is not compromised? Which vascular bed is not compromised? Answer is, next slide, next, coronary and cerebral. Okay, coronary and cerebral. That means আমি এতক্ষণ কি পড়ালাম? অ্যাকিউট করোনারি সিনড্রোম, তাই তো? সেটা কেন হয়? বিকজ অফ ডিক্রিজড ব্লাড सप्लाई इन हार्ट. ओके, हार्ट सबको ब्लड सप्लाई करता है बट हार्ट को खुद को भी तो ब्लड चाहिए बिकॉज ऑफ न्यूट्रिशन ऑफ द मायोकार्डियम, राइट? ओके, so whenever we are excited or in a stressful condition, if our coronary circulation is compromised, এটা যদি হতো তাহলে তো রোজই হার্ট অ্যাটাক হতো, সেটা তো হয় না, because heart has got its auto regulation. Similarly, brain has got its auto regulation, right? So even if in extreme condition your heart, your brain is capable of maintaining its circulation. Your heart, your brain is capable of maintaining its circulation. This is called auto regulation. And in the coronary circulation there is auto regulation, right? So the question is basically asking you which vascular bed has got auto regulations. Which vascular bed has got auto regulations? Okay, so mostly our cutaneous circulation suffers whenever you are excited or in a stressful condition. Cutaneous circulation, pulmonary circulation in the skeletal muscle drops, right, due to vasoconstriction. But due to vasoconstriction, your cerebral artery and your coronary artery, these are not affected. Okay, so what am I moving on? I am moving towards coronary circulation, the circulation system in the coronary artery, how myocardium gets blood, right? Okay, so our next topic is coronary circulation, that we will discuss in our next class. Okay, thank you.
তোদের পড়াশোনা করেছিস তোরা? এই পড়াশোনা করছিস না? বাড়ি থেকে মা বাবা পাঠিয়েছে, এত কষ্ট করে দূরে আছিস, হ্যাঁ? Good afternoon to all of you. Today's topic, heme catabolism. Perhaps you are recapitulate with the previous class where I taught about the heme synthesis and disease related with heme synthesis, that is porphyria. Some small portion of porphyria is even left. अच्छा, first হচ্ছে heme is a major hemoprotein present in blood. That is, what is the major hemoprotein present in our blood? হ্যাঁ মারবো একখানা। Major hemoprotein present in our blood, that is hemoglobin. তাই তো? হ্যাঁ, হিমোগ্লোবিনের হাফ লাইফ কত জানিস? মানে আরবিসির হাফ লাইফ হিমোগ্লোবিন কোথায় থাকে? হ্যাঁ না, সেটা তো সিনথেসিস হলো, কিন্তু আলটিমেটলি হিমোগ্লোবিনটা কোথায় থাকে? হ্যাঁ, আরবিসিতে হিমোগ্লোবিন থাকে। আরবিসির হাফ লাইফ কত রে? হ্যাঁ, 120 days. তাহলে আফটার দ্যাট হোয়াট উইল হ্যাপেন টু আরবিসি? হ্যাঁ, that will be destroyed. What will be the two component after destruction of RBC? মানে hemoglobin. Is it correct or not? তাই তো? হ্যাঁ, হিমোগ্লোবিন হলো, হিমোগ্লোবিন ডিগ্রেড করে ডিস্ট্রয়েড, তাহলে হিম আর গ্লোবিন হলো গ্লোবিন। হোয়াট ইজ গ্লোবিন? হ্যাঁ, প্রোটিন ইজ এ চেন অফ অ্যামাইনো অ্যাসিডস। তাহলে এটা হচ্ছে অ্যামাইনো অ্যাসিড হবে, এটা হচ্ছে রিউটিলাইজেশন হবে। রিউটিলাইজেশন হচ্ছে অ্যামাইনো অ্যাসিডগুলো, ঠিক আছে? আর এই নেক্সট পোর্শন হিম এবার ডিগ্রেডেশনে যাবে, সেই ব্যাপারটাই আজকে পড়ানো আর কি। এই হচ্ছে ব্যাপার, বুঝলি? ব্যাপারটা মনে থাকবে, এরকম না বললে আর মনে থাকতো না তোদের। ওই এরকম আরবিসি, হিমোগ্লোবিন, আর কি বলে তোর হিম প্রোটিন কোথায় আছে মনে পড়ছে না, মানে এগুলো তুই জানিস, বাট মানে ব্যাপারটা হলো হিমোগ্লোবিন ভেঙে হিম হচ্ছে, গ্লোবিন হচ্ছে, গ্লোবিনটা অ্যামাইনো অ্যাসিডে মানে কম কি বলে কনসিকুয়েন্সিয়াল যে অ্যামাইনো অ্যাসিড আছে সেগুলোতে কনভার্ট হবে, সেই অ্যামাইনো অ্যাসিডটা রিউটিলাইজেশন হবে, হিমটা ডিগ্রেড হবে। এবার এর আগের ক্লাসে যেটা বলা হয়েছে তোদের, হিম কি দিয়ে তৈরি? 4 পাইরল রিং আর আয়রন থাকে। আচ্ছা, তাহলে এবার হচ্ছে যে আফটার 124 days RBC get breakdown and heme and hemoglobin is produced. Globin is used for utilization and heme undergoes catabolism. Acha, what per day about 6 gram of hemoglobin is broken down. 6 gram per day hemoglobin broken down হয় in our body, that produce about 250 milligram per day bilirubin. বুঝতে পারছিস? আচ্ছা, এই গেল। Some small portion also produced from other heme containing proteins like myoglobin, তারপর আর কি বলেছিলাম, আর 4-5টা 3-4টে বলেছিলাম, হ্যাঁ, এরকম হতে পারে। ক্যাটালাইজ ছিল আর সাইটোক্রোম P450 এনজাইম সিস্টেম ছিল। এরা মোটামুটি আর কিছুটা ব্রেকডাউন করে হিম, ওদেরও তো হিম থাকে, সেগুলো ব্রেকডাউনের ফলে সামান্য পরিমাণ চলে, দ্যাট ইজ অ্যামাউন্টস টু 50 মিলিগ্রাম পার ডে। এবার ক্যাটাবলিজম মেটাবলিক পাথওয়ে, মানে মেটাবলিক না, মানে এটা the major site for catabolism, heme catabolism is reticuloendothelial system, RE system, that is liver and spleen. Catabolism mainly হয় liver and spleen. The enzyme system which is related with this catabolism is a complex enzyme system, heme oxygen, that is known as heme oxygenase enzyme system. Spleen, a complex enzyme system is associated with this catabolism. This is an substrate inducible enzyme system. কথাটার মানে বুঝলি? সাবস্ট্রেট মানে যেটা প্রোডাক্ট, ধর হিম, এখানে প্রোডাক্ট ইন্ডিউসিবল, যত হিম তৈরি হবে এনজাইম সিস্টেমটা তত অ্যাক্টিভেটেড হবে, ঠিক আছে? সাবস্ট্রেট ইন্ডিউসিবল enzyme system, that is heme oxygenase. It occurs in the microsome of cytoplasm of cell organelle. This enzyme system is present in the microsomes of cytosol. ঠিক আছে? হেমিনে আয়রন কি থাকে, কোন স্টেটে থাকে? হেমিনে আয়রন কোন স্টেটে থাকে? আয়রনে তো Fe2 থাকে। আছে কি একটা converted into hemine, that is ferrous iron is converted into ferric iron when it comes with the enzyme contact with the enzyme systems. This hemine then converted into or oxidized into heme. Next, in the next stage, with the help of NADPase, in the next stage, this product is goes further oxidation with the help of oxygen and NADPase plus H2 plus H, that is formed alpha, এটা হচ্ছে তোর alpha methynyl bridge causes oxidation of methynyl bridge at alpha position. This is an oxidation reaction. It undergoes further oxidation with the help of NADPase plus H plus, which causes breakdown of alpha methynyl bridge and causes a linear structure of tetrapyrrole ring. যেটা আমরা আগে দেখেছিলাম যে চারটে পাইরল রিং থাকে, তার হচ্ছে যে মিথেনাইল ব্রিজ দিয়ে কানেক্টেড থাকে, তার ওয়ান আলফা পজিশন, দ্যাট ইজ এরকম তো স্ট্রাকচারটা আয়রনের। এটা হচ্ছে যে আলফা মিথিনাইল ব্রিজ এখানে ব্রেকডাউন হচ্ছে, গিয়ে এটা হচ্ছে স্ট্রেট হচ্ছে, স্ট্রেট লিনিয়ার টেট্রাপাইরোল স্ট্রাকচার, দ্যাট ইজ নোন অ্যাজ বিলিভার্ডিন। এই যে দ্যাট ইজ বিলিভার্ডিন। This biliverdin undergoes reduction by biliverdin reductase that gives rise to bilirubin. এইভাবে bilirubin আমাদের বডিতে প্রডিউস হচ্ছে। The problem is that bilirubin has no function in our body. That's why not only non-functioning but also it is toxic to our body, especially for our brain. What will happen? It can cause up to convulsion, even death, especially in case of newborn child. Perhaps you are heard the name of neonatal jaundice. যেগুলো হচ্ছে neonatal period up to 14 days of 28 days of birth, that is known as early neonatal period. ঠিক আছে, তো এই পিরিয়ডে ব্রেনটার তো যেটা হয়, ব্রেন হচ্ছে ডেভেলপ করে না, ব্লাড ব্রেন ব্যারিয়ার আছে তো, যেটা কিছু কিছু সাবস্টেন্সকে ব্রেনে যেতে মানে ব্যারিয়ার সৃষ্টি করে, ওদের ব্লাড ব্রেন ব্যারিয়ারটা তৈরি হয় না, যে কারণে বিলিরুবিনটা ডিফিউজ করতে পারে। হিউজ ডিফিউশন পাওয়ার আছে বিলিরুবিনের, সেটা তো পরে বলবো আর কি। আচ্ছা, তাহলে এই বিলিরুবিন কজেস various disease in our body, especially that is known as jaundice. তাহলে বিলিরুবিনটা এর পরে নেক্সট ক্লাসে হবে। আমি আর আই এম নট গোয়িং ইন ডিটেল অ্যাবাউট দ্য বিলিরুবিন। Bilirubin, in a nutshell, this bilirubin is producing spleen, ঠিক আছে, স্প্লিন থেকে ইট ইজ কামিং টু hepatic cell. Bilirubin is insoluble in water. So if it is being transported in blood, it has to be dissolved in water. Albumin acts as a water carrier protein. And albumin bilirubin complex is transported through the plasma and comes into liver, where bilirubin is taken by the liver cell with a carrier molecule. ঠিক আছে, নেক্সট হচ্ছে যে ইন লিভার bilirubin is conjugated with glucuronic acid. This glucuronic acid conjugation causes the bilirubin a soluble product which is excreted, that is known as monoglucuronide or diglucuronide. Both the products are water soluble and they get excretion through bile. Through the bile it comes with into duodenum and thereby large intestine and thereby excreted by the feces, and some portion of bilirubin is absorbed by enterohepatic circulation. That portion comes into urine. In normal condition it is very negligible. বুঝা গেল? হ্যাঁ, কটা বাজে? এই তো আচ্ছা আর একটু চালাতা। আচ্ছা ঠিক আছে, নেক্সট আমি তোদের এটা মোটামুটি শেষ হয়ে গেল। বিলিরুবিন নেক্সট বিলিরুবিন আরও ইলাবোরেটলি পড়ানো হবে। হ্যাঁ, এটা জাস্ট একটা নাটশেল ব্যাপারটা কি হয় তোদের দেখালাম। এরপরে আমি আসছি যে পরফাইরিয়া। পরফাইরিয়া হচ্ছে যে কত টাইপের আছে আগের দিন আমি বলেছি। পরফাইরিয়াস খুব আনকমন তো নাকি, না খুব কমন? হ্যাঁ, porphyria is very uncommon disease, but yet we are reading this thing. ठीक है, अच्छा, porphyria occurs due to the deficiency, partially or complete deficiency of the enzymes related with the heme synthesis. আমি একটা তোদের আঁকাচ্ছি মোটামুটি, যেটা দেখলে বুঝতে পারবি আর কি। What is the main product for the synthesis of heme? Glycine. Form of PELA. Amino levulinic acid. चलो 2. Six. So if you look at this first porphyria is known as porphyria are categorized into two types. One is according to the causes, or one is according to the organ related with the porphyrias. First one is genetic and acquired. Genetic porphyrias are due to enzyme deficiency. This enzyme deficiency either partial or by complete. The enzymes, if you look at the chart, there are various enzymes associated with the porphyria heme synthesis. Another categorization is organ associated with the porphyria, that is hepatic porphyria and erythropoietic porphyria, and another is mixed porphyrias. Hepatic porphyria occurs due to enzymes associated with the liver, and the erythropoietic porphyrias are associated with the erythropoiesis, RBCs. এগুলো আগে তো দেখানো হয়েছে, ঠিক আছে। হেপাটিক পরফাইরিয়া আছে চার রকমের। একটা হচ্ছে যে এআইপি, এআইপি ফুল ফর্ম অ্যাকিউট ইন্টারমিডিয়েট পরফাইরিয়া। সেকেন্ড ইজ হচ্ছে হেরিডিটারি পরফাইরিয়া কিউটেনিয়াস টার্ডা। থার্ড ওয়ান হেরিডিটারি কোপ্টোপরফাইরিয়া। ফোর্থ ওয়ান ইজ পরফাইরিয়া ভেরিগেটা। এরিথ্রোপয়েটিক পরফাইরিয়ার ভিতরে আছে দুটো, কনজেন্টাল এরিথ্রোপয়েটিক পরফাইরিয়া আর প্রোটোপরফাইরিয়া। Okay, now I am coming to AIP. AIP is commonest porphyria that occurs in our day-to-day practice, that is acute intermittent porphyria. The enzyme deficiency is UPG synthesis 1. Have you seen UPG synthesis 1? Synthesis 1. That's why if the enzyme deficiency, then the intermediate products of above this synthesis level is increased in our body, that is ELA and UPG. These ELA and UPG are toxic to the autonomic nervous system. And the sign and symptom occurs with the autonomic nervous system. That is most common presentation is abdominal pain along with nausea, vomiting, diarrhea. Another sign and symptom associated with the psychiatric system, that is nervous system irritation, anxiety, depression, retention of urine, some others. Achha, how to detect it? The detection depends on the level of ALA and UPG in blood. That will be increased in our body, and urine. Another method of detection is enzyme deficiency detection. Okay. Treatment depends on the precipitating factors to be stopped, and IV glucose and heme is the main mode of treatment. Next I am coming to যেটা তোদের বলা হয়নি, porphyria cutaneous tarda. This acute intermittent porphyria and porphyria cutaneous tarda is differentiated by the photosensitivity. In case of acute intermittent porphyria, no photosensitivity is seen, but in case of cutaneous porphyria, photosensitivity is the major sign associated with this disease. Photosensitivity is one of the most common presentation of cutaneous photoporphyria. What is photosensitivity? Photosensitivity is presented as vesicle or bulla. Vesicle মানে ছোট্ট, bulla মানে আরেকটু বড়. Water filled vesicle or bulla over the exposed part of the body, that is hand, feet, মাউথ, এই সমস্ত পার্টে হচ্ছে যে ভেসিকল আর বুলা দেখা যাবে। আর একটা ইয়ে হচ্ছে যে স্কিন ইজ ভেরি ফ্রায়েবল। ফ্রায়েবল কথাটার অর্থ হচ্ছে যে তুই টাচ করলেই ও মানে ছিঁড়ে যাওয়া আর কি, মানে ভেঙে যাওয়া আর কি ফ্রায়েবল বলা হয়। মানে দ্যাট ইজ স্লাইট ট্রমা কজেস ইনজুরি টু দ্য স্কিন। ঠিক আছে, দ্য ডেফিসিয়েন্ট এনজাইম ইজ UPG decarboxylase. This causes cutaneous porphyria tarda. For that, what will happen? Porphyrin level in our body, in blood, is increased. This porphyrin causes photosensitivity. Detection level একই, mode of detection, increased level of porphyrin, আর হচ্ছে enzyme deficiency. Treatment হবে হচ্ছে যে কিছু প্রেসিপিটেটিং ফ্যাক্টরস থাকে, সেগুলোকে ড্রাগ থাকে যেগুলোকে স্টপ করতে হবে। আর আরেকটা হচ্ছে যে ক্লোরোকুইন দেওয়া হয়। ইন কেস অফ cutaneous porphyria tarda, chloroquine is given, low dose chloroquine is given, that causes excretion of porphyrin through the urine. Okay, আর কিছু তেমন আর কিছু নেই তেমন। ওকে, এই that is all about today. Next, bilirubin will be taught in elaborately next class. Okay.
That is superficial mycosis. Lot of question asked from this particular chapter in the final examination, and a very important chapter for theory purpose. What is superficial mycosis? An interactive session. My question is, what is superficial mycosis? Any answer from your side? What is superficial mycosis? This is a picture of superficial mycosis. Petris is versicolor. Malassezia farfar, a very common condition. Patients with these particular infections are frequent, and often we treat with few drugs that we have, antifungal drugs. Anybody can name this condition? Yes? Sorry? What type of superficial mycosis is this? You can see the hypopigmented and as such as hyperpigmented areas on forehead. Hypopigmented as well as hyperpigmented scaly spots on the forehead. Not only on the forehead, also in the back and other portions of the body. What is the condition? This is so-called chuli. So-called chuli. Frequently, আমরা এটা দেখি না আউটডোরে সাদা সাদা স্পট হয়েছে পেশেন্টের শরীরে সুপারফিশিয়াল স্কেলি লিশন খুব দেখা যায় ডার্মাটোলজি ওয়ার্ডে যদি তোমরা যাও ডার্মাটোলজি ক্লিনিকে যদি যাও খুব ফ্রিকোয়েন্টলি দেখতে পাবে the causative agent is tinea versicolor, different type of color, hypo and hyper, so different type of color, tinea versicolor or Malassezia farfar. So please write few oral questions on superficial mycosis. Where they colonize the superficial fungus, they colonize on the which layer of skin? The superficial fungus, they colonize on which layer of skin? Yes, stratum corneum, that is the, write down, please write down. The causative fungi colonize only on the cornified layer, only on cornified layer, cornified, C-O-R-N-I-F-I-E-D, cornified layer of skin. Please write down the answer. What is superficial mycosis? This will be asked in the oral examination. What is superficial mycosis? M-Y-C-O-S-E-S, mycosis. The fungal infection affecting the cornified layer of skin. They never penetrate into the deeper layer. They never penetrate into the deeper layer. Always superficial. The causative agents are, what are the causative agents? Malassezia farfar, Malassezia. Malassezia farfar, F-U-R, M-A-L-A-S-A-Z-E-A, Malassezia farfar, F-U-R, Malassezia farfar, comma, tinea, T-I-N-E-A, tinea species, S-P, comma, piedra, 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 black or white, and dermatophytes. This is the complete answer. Now, how to identify Malassezia? This is hypopigmented spots on back, chuli, caused by Malassezia parpar, and this is superficial mycosis. Hyperpigmented patch, superficial fungus. The KOH preparation, 10% KOH preparation usually used for skin. For nail, we can increase the concentration to 20 to 30%. So 10% KOH is used for fungal preparation, is known as fungal preparation. What is the role of KOH? What is the role of potassium hydroxide? It is a clearing agent. It liquefies the fungal different layers of the skin, and fungi are easily visible. So it is a clearing agent, KOH. The classical appearance is spaghetti and meatball. Yes, this condition, this picture is known as spaghetti and meatball appearance. These are the meatballs, fungal balls, and the hyphae, these are called spaghetti and meatball. Meatballs, rounded, small, spore-like structures. Under KOH preparation, this is clearly visible. In methylene blue preparation or any other stain used, especially in 10% KOH, if we add any color, the picture will be like this. So this is known as spaghetti and meatball appearance, classical. You have to mention the particular terminology, spaghetti and meatball appearance, sir. Is it clear? So from scrape lesion, from scrape of the skin, you take the material, the superficial layers of skin, and under KOH preparation, you will be able to see this particular picture known as spaghetti and meatball appearance of the fungi. The pityriaceous versicolor in SDA media. What is the full name of SDA? What are the composition of SDA? Separate dextrose, the composition is dextrose and agar. SDA, it's very clear. SDA, take D for dextrose and A stand for agar. So separate dextrose, agar. The culture typically shows, can you describe this picture? This picture, fungus is always cultivated under two conditions. Considering the dimorphic nature of the fungi, The fungi, they are cultivated usually in the 37 degrees centigrade as well as 25 degrees centigrade. So cultivation in two different environment is required, 25 as well as 37. So 37 degrees centigrade. This picture is typically, can you describe the colony? White, velvety appearance, well defined, almost well defined, and as well as woolly appearance, white woolly appearance, this will also do. So this is the typical characteristics of this fungus. And fungi growth, these are observed usually on the reverts and as well as on the obverts. Say for example, this is the colony in a petri plate. So we have to see on the front side as well as on the back side. Two different observations are required. So always observe before examiner, the front side is obverts and the back side on the reverts. The two different pictures may be possible. On the obverts, there may be white side, white colony, and on the reverts, there may be red colony. These are also the possibilities. So always show him, sir, yes, this is the front side, and try to see the reverse of it. For cultivation of Malassezia, for cultivation of Pityriasis versicolor, we used one chemical for improving the growth, one particular oil-like substance. What is that? Olive oil. We use olive oil for promotion of growth. So which species of Malassezia, question, which species of Malassezia is lipid independent? Is lipid independent? Answer, Malassezia pachydermatis. Pachydermatis. Malassezia pachydermatis. This is a particular species where olive oil is not required. So it is independent of any oil. Malassezia pachydermatis. What are the clinical conditions? What are the clinical conditions caused by Malassezia? What are the clinical conditions caused by Malassezia? Number one, erythema. Erythema. Number two, hypopigmentation. Number three, hyperpigmentation. Hypo and hyperpigmentation. And number four, scaly lesions, scales, superficial scales, scaly lesions. What is the characteristics of scales of Pityriasis versicolor under wood light? Have you heard the name of Wood's lamp? Yes. So, under Wood's lamp, we will be able to identify the nature of the fungi. Wood's lamp, the characteristic color will be what type of fluorescence? Golden yellow fluorescence. Very good. Golden yellow fluorescence. So, golden yellow fluorescence under Wood's lamp is visible. Malassezia, Malassezia farfar, তো সুপারফিশিয়াল মাইক্রোসিসের কথা বলছি। What is diatomaceous fungus? What is diatomaceous fungus? These are pigment producing fungus, pigment producing fungus of the superficial layers of skin. Example, Tinea nigra. Tinea nigra. Nigra means black. Nigra means black. Usual site of infection, palm. এখানে হয় কালো কালো রঙের scaly lesions, black color. Itchy lesions, খুব চুলকোয়। Caused by Tinea nigra. KOH preparation. How to identify the organism? Scrape smear taken from the palm lesion. From superficial lesions, crepe lesions are taken, crepe materials are taken, and under KOH preparation, the observation is like that. Under KOH mount, the observation is like that. Fungal hyphae are seen, and along the hyphae, along with this hyphae, this fragmented hypha is called. The fragmented hypha is called. Fragmented hypha is called arthrospore. What is arthrospore? The fragmented hypha is arthrospore. So these are all fragmented hypha. These are fragmented hypha. This is the complete hypha. And now these are fragmented. The fragmented hypha is called arthrospore. Can you name few black yeasts? Black yeast, colored fungi, black yeasts. Right? And Madurella species. They form black spore. Causative agents of actinomycetes. Madurella mycetes, Exophylla genselmi, and Madurella and Madurella mycetomatis, and white pigment producing mycetoma, Acrimonium genselmi and Pseudoalasteria boydii. Very good. Try to remember. So, black yeasts are, or black fungi are, especially black yeasts. I have mentioned these black yeasts, not hyphae, black yeasts. These are number 1, Hortia warnecki, Hortia, Hortea, Hortia warnecki. Exophylla spinifera, Exophylla species, and also Exophylla genselmi. Then what is Piedra? Piedra Piedra. Everything is cutaneous. Hey, Piedra কি? বল, হ্যাঁ জানিস? পিয়েড্রা বল। পড়েছিস পিয়েড্রা? পড়েছিস? আমাকে আগে বলেওছিস। কোথায় হয় পিয়েড্রা? দোষ, বলেছিস আগে, এখন ভুলে খেয়েছিস। আগে বলেছিস আমায় পিয়েড্রা পায় না, পা থেকে আস্তে আস্তে উপরের দিকে ওঠ। কোথায় হয় পিয়েড্রা? যা, কি পড়ালাম রে? It is a superficial infection of hair shaft. আরে চুলে হয়, হেয়ার শাফটে হয়। কতবার বলেছিস তো? আমি অনেকবার জিজ্ঞেস করেছি, আমাদের ইন্টারঅ্যাক্টিভ ক্লাসগুলোতে অনেকবার জিজ্ঞেস করেছি, অনেকবার সাকসেসফুল অ্যান্সার পেয়েছি। চুলে হয়, হেয়ার শাফটে। তোর একটোসিস এন্ডোসিস বলিস নি, এবার তো পরীক্ষাও লিখেছিস, তাহলে সেটা ভুলে খেলি। হেয়ার শাফটে হয়, মনে পড়ছে এবার? তাহলে লেখ, it is a superficial infection of hair shaft characterized by forming nodules, ছোট ছোট nodules হয় hair shaft এ, composed of fungal element. Hair shaft এ fungal element হয়, composed of fungal element. They are usually of two types. তবে হোয়াইট পিয়েড্রা অ্যান্ড ব্ল্যাক পিয়েড্রা, দুটো টাইপ, দু রকমের হয়, হোয়াইট অ্যান্ড ব্ল্যাক। হোয়াইটটা কি দিয়ে হয়? ট্রাইকোস্পোরান বিজেলি, অনেকবার বলেছিস, ট্রাইকোস্পোরান বিজেলি। অ্যান্ড ব্ল্যাক পিয়েড্রা হর্টিয়া। ভেরি গুড। যারা বলতে পারছো না তারা বুঝতে পারছো কোন জায়গায় আছো, ও জায়গাতেই থাকো। কালচার সেন্সিটিভিটি এক্সামিনেশন এসডিএ মিডিয়াটা মনে রাখবে, তার সঙ্গে সঙ্গে অলিভ অয়েল কথাটা মনে রাখবে সুপারফিশিয়াল ফাঙ্গাসের জন্য, টু ইনক্রিজ দ্য গ্রোথ অফ সুপারফিশিয়াল ফাঙ্গাস। আর কিছু যদি মনে না থাকে, ফর অল সুপারফিশিয়াল ফাঙ্গাই দ্য গ্রোথস আর ক্রিমি হোয়াইট, ক্রিমি হোয়াইট উলি, ক্রিমি হোয়াইট গ্রোথটা লাগিয়ে দেবে। যদি কিছু মনে রাখতে না পারো তাহলে ফর অল সুপারফিশিয়াল ফাঙ্গাস দ্য গ্রোথ ক্যারেক্টারিস্টিক্স অফ in SDA is same, almost same. সুতরাং এটা লাগিয়ে দেবে, ক্রিমি গ্রোথ। উলি দিতে পারো, উলি, ক্রিমি, হোয়াইটিশ, এটা লাগিয়ে দেবে। So what is arthrospore? What is arthrospore? Fragmented hyphae is arthrospore. এটা কি? খুশকি হয়েছে মাথায়। From now on তোমরা কি বলবে? খুশকি হয়েছে মাথায়, সাদা সাদা হয়েছে, সেটা কি? এটা ফাঙ্গাল ইনফেকশন স্যার। কোন ফাঙ্গাস? কোন ফাঙ্গাস? ট্রাইকোস্পোরন বিজেলি। খুশকি পেশেন্ট বলবে এখন থেকে, ড্যান্ড্রাফ খুশকি এরা পেশেন্ট বলবে। ক্লিনিশিয়ান কি বলবে? ইট ইজ ট্রাইকোস্পোরন বিজেলি ইনফেকশন, যদি সাদা সাদা হয়। বোঝা গেছে? আরো সব ওয়ার্ড ইউজ করবে না, ওরা পেশেন্টরা নেট দেখে এসে বলে ড্যান্ড্রাফ হয়েছে, ডাক্তারবাবু ড্যান্ড্রাফ। তোমার প্রভিশনাল ডায়াগনোসিস হবে, তুমি কালচার করোনি তাই তোমার প্রভিশনাল ডায়াগনোসিস হবে একটা কোয়ারি দিয়ে টি বিজেলি। পেশেন্টের মাথায় এরকম দেখলে উডস ল্যাম্পে দেখতে পারো, অথবা ভালো করে মাথার চুলগুলো সরিয়ে সরিয়ে দেখতে পারো। দেখলে এরকম দেখতে পাবে। নিজেদের মাথার কথা আমি বলছি না, পেশেন্টের মাথাটা দেখো। প্রত্যেকদিন স্নান করার অভ্যাস থাকা আর না থাকার মধ্যে অনেক ফারাক। এটা কি? পিয়েড্রা হটিয়া। হেয়ার শ্যাফট। হেয়ার শ্যাফটের মধ্যে কি দেখতে পাচ্ছ? অবজারভেশন বলো, কি দেখতে পাচ্ছ হেয়ার শ্যাফটে? বাইরের দিকে কি দেখছো? হেয়ার শ্যাফটের বাইরে ফাঙ্গাল ইনফেকশন হয়েছে। হেয়ার শ্যাফটের বাইরে ফাঙ্গাল ইনফেকশন, তাহলে এটা কি? একটো না এন্ডো? একটোথ্রিক্স। এটা একটোথ্রিক্স। একটা হেয়ার নিয়ে, চুল নিয়ে মাইক্রোস্কোপে আমরা দেখি, মাইক্রোস্কোপে হেয়ার শ্যাফটের বাইরে যদি দেখা যায় তাহলে একটোথ্রিক্স। আর ওটা ভেতরে কি দেখা যাচ্ছে? ভেতরে খুব ভালো করে তাকিয়ে দেখো, ছোট 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 এই যে কালো কালো কালো, মাঝখানে সাদা সাদাও আছে, লম্বা, এগুলো সব ফাঙ্গাস হাইফি। ভেতরে হয়েছে, বাইরেও হয়েছে। এন্ডোথ্রিক্স। এন্ডোথ্রিক্স ভেতরেও হয়, বাইরেও হয়। তাই বলে সেটাকে আমরা অনেক সময় একটো এন্ডোথ্রিক্সও বলি, কিন্তু আইডিয়ালি এন্ডোথ্রিক্স ভেতরেও হয়, বাইরেও হয়। তাহলে ফাঙ্গাল চেইন যদি তুমি চুলের ভেতরে দেখতে পাও তাহলে সেটা হচ্ছে এন্ডোথ্রিক্স। তাহলে তাহলে আইডেন্টিফিকেশন কি করে করবে? হাউ টু আইডেন্টিফাই ট্রাইকোস্পোরন বিজেলি অ্যান্ড হটিয়া? হাউ টু আইডেন্টিফাই? হাউ টু আইডেন্টিফাই দিস থিং? যেটা চোখে দেখলে সেটা কি করে করবে? না না, কি করে করবে? ক্লিনিক্যাল এক্সামিনেশন, পেশেন্টের থেকে কি নেবে? ম্যাটেরিয়াল, হেয়ার প্লাক করবে, চুল তুলতে বলবে পেশেন্টকে। এই এত গরম হচ্ছে কেন? চালিয়ে দাও তো, ওদিকে তুলো।